Any of you who want the chocolate pudding to be parceled, please contact the IT department. They are responsible for everything. So, so let's start the potpourri session. Please welcome our esteemed moderators to, on their seat. Dr. Jagdish V, Director, Department of Anesthesiology, Shankar Nethralaya, Chennai. Dr. Alfred Chua, Senior Anesthesiologist, Royal Prince Alfred Hospital, Sydney. And Dr. Kannan R, Senior Anesthesiologist, Shankar Nethralaya, Chennai, MIOT Hospital, Chennai, ICU and Emergency Department. Yeah, potpourri basically means a mix of everything. So it's an ideal session after lunch. So I invite our first speaker on stage, Dr. Paul Williams, or rather our first speaker for the second time today, Dr. Paul Williams, VMO Anesthetist, Royal Prince Alfred Hospital, AMA, Australian Society of Anaesthetists. He has several national and international publications with areas of interest, anesthesia for glaucoma surgery and cornea transplant. So today he'll talk about stop before your block. So please join me in welcoming Dr. Paul Williams. Over to you, sir.
Thanks very much for the introduction, and thanks for having me back on stage again. Can I have the... Thank you. I think as anaesthetists, as a profession, we're really exceptional at safety. It's something that as a profession over time we've actually improved a lot of other specialties, particularly surgery, in safety, but we're always looking for something more. I'm giving this talk because this is a conference about safety, and I was asked to send in some ideas, and I ran that risk, and I have the complication of the talk. But the talk is about stop before you block. It's essentially a safety initiative aimed at decreasing the incidence of wrong-sided and wrong-sighted blocks. It's predominantly been directed at peripheral regional anaesthesia, and it aims to provide a short moment of conscious thought prior to performing a skilled task in a time-pressured environment. And always, as we know, it's a challenging environment. And the idea is to try and decrease the incidence and error of potentially consequences of that rare event. The trigger for the initiative started in 2010 from a report from the National Reporting and Learning Service in the UK, based on information from the Safe Anaesthesia Liaison Group of 67 wrong-sided blocks over about 15 months. The report actually recommended that a surgical site mark should be checked, such as the WHO sign-in, and also that the surgical site should be marked. When Nottingham University Hospital had a look at their data, they had 5 cases over a 12-month period, and actually those 5 cases, all of them had had a WHO sign-in, and they had had the surgical mark appropriately marked. So obviously they went back to the other data and they looked at the 67 wrong-sided blocks. And similarly, they had also had a surgical site marked appropriately, and the WHO sign-in had been done. So it was clear that another approach or some other approach was needed. Hence the initiative was commenced, and it was based on the common risk factors that were identified in those 67 cases and since then. We can break up these risk factors into human factors and system factors. The human factors we all experience every day. We have a perceived time pressure, whether that's real or not. We're often distracted in a busy environment. We suffer from mental fatigue and often cognitive overload. From multitasking, information processing, we're often interrupted while we're doing complex tasks. And often ambiguous terminology is used both on the consent form and by health staff. And during a busy day, often we have staff changes within that period, and the staff change can actually lead to loss of information and loss of a plan that you've already made. The system factors that we see are a lack of visible surgical site mark, particularly they note on lower limbs, which is not that relevant to us. Turning or moving the patient, and that can be laterally or moving them within the room or from when you've had your consultation with them. Bilateral surgery or bilateral pathology can be confusing because there's potentially two options and you might go to the incorrect one. And also it was identified that those who had a significant time lapse from the WHO sign-in to the performance of the block were at risk of having a wrong-sided block. So how big is the problem? It's actually pretty small in a way. The incidence is about 0.03 to 0.04, so that means about 1 in 2,500 blocks is estimated to be wrong-sided. But a wrong-sided block has the usual risk factors of any block that you perform. But it could be equally or more devastating to the patient who's had an unnecessary procedure. It can lead to the cancellation of the surgery, and also it can lead to a limitation in the local anaesthetic that you've used in a high volume block. In that circumstance, if you choose to proceed, could lead to local anaesthetic toxicity. Litigation often can ensue from that, particularly because this is essentially a trespass on an unconsented body part. And if in Australia at least, if there was a complication arose from a wrong-sided block, that would be indefensible, and that's clearly stated from the insurance companies in Australia. Worse still, if it's not recognised, you don't have any complication, but it could actually lead to the surgery occurring on the wrong side or the wrong site. So what is it? The block timeout should be a short moment in time performed by the anaesthetist and the assistant. It always should be preceded by the WHO surgical sign-in and verifying the patient identity, surgical site and the mark. You have to ensure the documentation is unambiguous, and that's both to the staff and to the patient before starting. You need to speak directly to the patient, and preferably whenever possible, and if it's not possible, the patient's relatives, or confirming with the surgeons or any imaging that might be available. You need to confirm the surgical site mark, and it should be confirmed at a mark placed near the block site, which for ophthalmic anaesthesia is often the same mark. When you do actually perform it, you're actually about to do the stop before you block. You should do it when you pick up the needle. So you have your needle in your hand, your assistant's there, and the patient's in front of you. And for me, it's preferable to have the consent form sitting on the patient's chest, which for ophthalmic anaesthesia is very useful. So I can see the consent form, the list, the nurse, and the mark, all in the same position, or at least from where I'm standing. So essentially we go through the process of confirming the side. On the written consent form, we can confirm the side of the procedure and confirm that with the patient as well. Often when I do that, if I'm not sterile, then I'll touch the patient on the side or the site so that they have another sensory level to confirm. And it also provides a visual cue to the nurses assisting you, who's standing there, can see the consent form, because every now and then you make a mistake and you say, I'm going to operate on your left-hand side, and someone corrects you. Because you've given other cues, you've got a bit of redundancy in the system. So during this process, the block site is confirmed again, and then if anything changes, any of those risk factors enter into that environment, you should start again and go back to confirming again. When I make a mark, I prefer to put an indelible mark over the eye. Patients don't like it because it doesn't rub off, but it can't be moved either. It's for eye surgery, particularly for cataract surgery, it's a very good time to confirm if it's a toric lens, and there needs to be alignment marking and confirm that that's been done. And you can also confirm that the correct side has been dilated, because that can be something in that risk factors list that the incorrect eye is dilated, and you just go towards the dilated eye. So I'd like to show you a video which is produced by ANSCA, and it tries to explain some of those factors that come in to the environment which you see on a daily basis. I'll see if it'll play. I hope it's got volume.
Here's how. Distraction. Change in position. Sedation. Time pressure. Each of these factors can lead to a wrong-sided block. However, this can be easily prevented by performing a pre-procedure timeout. This consists of a stop moment performed immediately prior to needle insertion, where an anaesthetist and assistant confirm the side via sight mark and consent form. What you have just seen is an example of a block timeout done well. Through this simple safety initiative, we can prevent the risks of wrong-sided blocks. Today, a surgeon would not perform a procedure without first confirming the side of the procedure. So we should not perform a block without first confirming the side of the block.
So if you choose to implement this process, there's some steps you need to take in order to do that. And you need to try and provide saturation of your environment, because they're rare events. You need to have everybody on board, or at least be doing the processes as much as you can within your department. And you need to try and empower and educate the entire team, and that requires a departmental approach and support from both the department and your hospital. The process should be an expectation amongst the staff. It's not a I might do it or I will do it, it's a you have to do it. And it's an importance should be emphasised repeatedly prior to disseminating the program. The process and its importance should be explained clearly at the departmental level, and education should involve the entire anaesthetic department, the nursing department, and the perioperative nurses and assistants, and preferably all together as well, and all in close time frames. Prior to the implementation, you should do some advertising, and that advertising can be posters and email and SMS, and these should be presented in any location that a block might reliably there should be an expectation that a block might be performed in that area. Once disseminated, the individual patient's block timeout should be able to be initiated by anybody on the team. So you've got the whole team aware, and they're all able to say, we need to stop before your block and do a timeout. And what this does is provide some consistency, having the whole team involved. It should also be simple and quick. It shouldn't really interrupt your flow too much. Once the process has been rolled out, obviously it's sensible to do an audit and try and pick up how much it's been promoted, see if the education is still remembered, and see how many people have actually adopted the process. And like any audit, that should be repeated at regular intervals. A system for error reporting should be available, and that should be at least at a departmental level with M&M, preferably a national level, and ideally on an international level. The two forms that are produced by the Royal College of Anaesthetists, which is on your left, and the Australian and New Zealand College of Anaesthetists is on the right. But basically, for this whole idea to work, you firstly have to have community awareness, you have to have mass uptake, and you have to have a system in place which is actually quite sophisticated. And that we try to have that in our daily working place. And because this relies on human performance, in order to make it successful and in order to decrease the incidence of wrong-sided blocks, it needs to be performed well 10,000 times in order to avoid 3 errors. So it's very difficult to achieve. So if we look at the human factors, the things that we need to look at is what's effective. So the chart with the green to red, all the things we've spoken about are basically down the bottom of that chart. They're not the most effective ways of making sure that something happens. When we look at the human factors, we need to make it as simple as possible with as few steps as we can possibly have. And we have to have this system standardised, because when it's standardised, it removes unnecessary variation and confusion. Like me saying, oh no, I don't do it now, I do it at this point in time. And that just collapses the whole process. And it also promotes predictability and consistency among the whole team. You need to use redundancies, and a part of that is actually doing the stop before you block. There's a redundancy in the system then before you do it, after the WHO sign-in, and before starting the surgery. One way of ensuring that a system works is designing the system with forcing functions. Now, a forcing function is a human behavioural science term, and it relates to a design that prevents the user from taking action without considering the relevant information to that action. And really what it tries to do is force people to be conscious in their thoughts. What it tries to do is disrupt normal, efficient, automised performance of tasks, which we do every day. When you have 10 blocks to perform, they're all on the left-hand side. You don't need to think too much about it when you've done several thousand of them before. And you need to stop every now and then and consciously think, what am I about to do? So the forcing function, it's difficult in our situation where there's a lot happening, but the best place that I work at that tries to do this, they don't do the block time out as such, they don't have the posters up. But when I'm presented with the patient's under a blanket, they're tucked in, the consent form's on their chest, and their eye is marked. And that nurse does not let me do anything until I pick up that form and read it. They're very polite about it, but that's the first thing I have to do. And in order to pick up that form, I can't put in the cannula before I pick up the form. I can't get to the arm without picking up the form. And invariably, if you're polite enough, you generally speak to the patient as well before you pick something up off them. So it almost creates that communication, which we usually do, but it actually forces you to do that. In a simple way of thinking about forcing functions, it's like opening a door. If there's a handle, you tend to pull it, even if it says push on the door. But if there's no handle, you tend to look at the sign and push the door. So I've not got long left. This slide tries to make us look at what we're actually doing when we have a safety focus. So on the left-hand side, there's the focus on safety things and critical incidents and root cause analysis, which is easy to see, but it's actually a complicated process to work it out. And that's most of the things we look at. On the far right are all the things, the exceptional people who do amazing things, and we can see that, but it's very hard to replicate, and it's hard to replicate on a large scale. What the airline industry tries to look at is the normal daily process, the things that we do really well, and the times we do it 2,499 times well, and actually improve that process so it actually spews over into the other areas. Because it's difficult to look at a null hypothesis and say that we're making improvements when what you're looking at is so small and it's at a negative value. So this is and partly because we have concerns, we want to know more. We want to say, well, I'm interested, but I want to know how it works, and why I have to do it. And it takes a long time to bridge that gap. And I think if you're going to do nothing else, you can look at that and say, at least be honest about where you sit on that, because then you can understand your own reactions. When someone tries to bring in innovation, you can understand your response to it. Thanks very much.
Thank you, Dr. Paul. That was indeed an excellent talk with a lot of take-home points, very well demonstrated videos and images, especially the innovation distribution curve. So next I would like to welcome on stage Dr. Chinmay H. Vyas. Dr. Chinmay is a vitreoretina consultant at Netradhama Super Speciality Eye Hospital, a very dear colleague and friend. She's presented over 20 presentations in national and international conferences with over 15 index publications in various journals. Her areas of interests are vitreoretina, ophthalmic anesthesia, and ocular genetics. Today, Dr. Chinmay is going to speak about how to recognize and manage glow perforation following regional anesthesia. So please join me in welcoming Dr. Chinmay on stage. Over to you, Dr. Chinmay.
Good afternoon, everyone. Today I'll be talking mainly about the recognition and management of globe perforation following regional anesthesia. I'll be mainly focusing on the vitreoretinal complications which are present and the management of that. A direct globe injury during an orbital anesthesia is a rare but a devastating complication, and the incidence has come down over the period of years as the regional anesthesia techniques are developing and they're getting more safer and safer. However, more than 50% of the iatrogenic penetrations and perforations undergo unrecognized, and early detection and prompt treatment is of paramount importance in managing direct globe injuries. So what I was given the topic, it was called as direct globe injury and globe perforation. So I wanted to just discuss what is different between a globe perforation and a penetration. A globe perforation is when there's an exit and an entry wound, while in case of a penetration, there's only an entry wound which is present. And this is extremely important in terms of vitreoretinal injuries. Globe perforation, which would have an extensive tissue damage, and it's much more difficult to treat. There are more chances of retinal detachment and injury to posterior pole and to the optic nerve. Obviously, globe perforations have much poorer prognosis as compared to simple penetrating injuries. Penetrating injuries are far more common than perforating injuries. The factors that generally affect the perforation injuries are anatomical factors and psychological factors, which needs to be kept in mind. Elongated eyes, posterior staphyllomas, I'll be discussing this in detail with. So the patient factors would be the elongated eyes or high myopic eyes, where there is an increased axial length, and myopic eyes are at about 30% greater at risk of developing a perforation or a penetration. And the scleras are also thinner in myopic patients, and the orbit also has greater axial length. And so there is an increase in evidence in literature that about axial length of more than 26 mm is particularly at a higher risk of globe perforation. And retrobulbar blocks are at a higher risk of having, because the needle actually goes very close. Posterior staphyllomas are basically outpouching of the globe, which are seen very commonly with myopes, and the positions of posterior staphyllomas are mainly seen in the infratemporal parts, and while giving the infratemporal injections, they are at a higher risk of perforating or a penetrating injury. And there is also distortion of the globe anatomy, which makes them at a higher risk of globe penetration. Patients who have undergone any kind of retinal surgeries with explants like scleral buckles, there will be extensive conjunctival adhesions which are present, and that also limits the space and also changes the tissue consistency. So when a needle is actually being advanced through a globe where an explant is present or a conjunctival peritomy was done, you will have there will be a difference in the density, and the needle will not be able to differentiate between a globe and normal conjunctival tissue or a scarred scleral band. So there is a very high risk in patients who have undergone retinal surgeries for a regional block. Here I just wanted to discuss very briefly about the globe anatomy, where so the orbital axis is basically the bisection of the line between the medial and the lateral orbital walls, and visual axis is basically the position of the eye in the primary gaze. And these two axes are of an extreme importance. They make an angle of 23 degrees, which basically is the primary position. And the equator of the globe is the greatest diameter in the coronal plane, and it is extremely important to understand what is the greatest diameter of the coronal plane in order to avoid any kind of injury in this direction. So that is other factors which affect globe buffer injury is basically a forward set globe, where the globe extends forwardly over the infraorbital rim more than 8 mm, and the eyelids are much more lexed, and they have higher brows. So in these cases also the globes and the apex of the orbit are vulnerable to injury. Deep set eyes, the globes are basically set in, and they also have high arches which are difficult while giving a block, and the angle should not be angulated more than 10 degrees in a transfer plane to avoid any kind of injuries. Craniofacial abnormalities also are one of the major factors, so that has to be kept in mind. Other factors which affect are uncooperative patients, anxious patients. Any kind of sudden movements can affect, can cause a globe injury, and it's imperative that all patients undergo a thorough preoperative assessment, including history and physical examination, and open communication regarding the procedure of the block. The risk and the potential complication of regional anesthesia has to be discussed. Anxiety limitation is also extremely important, and anxiolysis without any kind of deep sedation should be the goal. And where explanation and reassurance are inadequate, it's better to plan a sedation also. I think the anesthesia colleagues will be more than happy to take over at that point. The other factors are the procedural factors. That could be the needle type, repeated number of injections, the types of block, personnel factors, and the technique of block. I found a lot of literature regarding use of blunt needles and fine tip needles, and most of the literature, the older literature, was suggesting that blunt needles are better because the proprioception that a blunt needle gives in recognizing the resistance of a globe is much higher as compared to a finer needle. However, if a perforation or a penetration does occur with a blunt needle, it's much more damaging to the globe. And what I felt was that blunt tip needles are much more painful, and so it causes much more patient discomfort. In our practice, we use fine needles, about 26 gauge or a 24 gauge if required. Needle length, there is increasing evidence saying that shorter needles are better. Number of injections, definitely the higher the number of injections, the more is the chance of having globe injuries. So different types of blocks. I found a retrobulbar block basically was associated with much higher risk of globe perforation as compared to any of other. However, I also found a lot of literature where there was a globe injury associated with lid block. Is much higher, and therefore the complications associated with that are also higher. So I think the thing that we need to mainly concentrate would be the peribulbar and the retrobulbar blocks. I also found literature regarding the techniques of block, where they said that judging the equator, as I said, is essential in assuring the safety of needle blocks. And initially, the recommended globe position of up and in is to macular area much closer to the needle lip, so that needs to be avoided. And always the needle orientation should be much tangential to the block, which is imperative. Personnel factors in the sense that a sound anatomy, knowledge of anatomy and physiology also is extremely important while giving the block. And a thorough pre-procedural evaluation to note the changes in anatomy is also very important. The sequence of event that happens during a globe injury, it starts with a scleral injury followed by a choroidal injury. There can be retinal injury and intraocular injections of the medication, and a perforation where there will be an entry and an exit wound. So the possible outcomes of a globe perforation would be a partial thickness scleral injury where the needle just grazes the sclera but does not go intraocularly. There can be choroidal injuries, choroidal detachment, injections of the intraocular, injections of the anesthetic agent into the choroids, which can lead to either a choroidal detachment or a hemorrhagic choroidal detachment. Retinal injuries can range from a grazing injury to the retina, retinal breaks. There can be retinal detachment associated with that. Retinal incarceration, this happens especially when a blunt needle or any form of needle is injected and perforates the globe. And while taking it out, the retina and the vitreous can be sucked in because of the negative pressure that it causes. So retinal incarceration is one of the very rare injuries that can happen. Direct injury to the fovea and optic nerve has also been noted. Vitreous injuries would be vitreous hemorrhages, incarceration of vitreous in the wound, vitreous tractional bands. Proliferative vitreoretinal changes are also seen very often in retinal detachment. However, an injury to the globe, whether it's globe perforation because of a nitrogenic needle injury or if it's a direct injury, any perforating injury, acts or behaves in the same way. So the type of proliferative changes which are seen after injury are much more severe and the inflammation is more. There can also be intraocular injections and toxicity associated with that. So experimental evidence suggested that intraocular injection of lignocaine is not really toxic to the retina. However, hyaluronidase, which is given as an adjuvant to injections, which to increase the block efficiency, does cause toxicity to the retina. And so if there is any evidence that an intraocular injection has been placed and hyaluronidase was added to the solution, then it's always better to take up that patient early for a vitrectomy to remove the vitreous and to prevent any kind of injury, any kind of retinal toxicity. Sterile or infectious endophthalmitis is also a rare but a possible thing that can happen, and patients do react to the intraocular injections, and that can cause a sterile endophthalmitis, which needs to be treated again with either vitrectomy or any kind of retina procedure. Ocular explosion or a ruptured globe is a possible, it's a possibility when there is an inadvertent injection of local anesthetics into the globe. That can cause rupture of the globe. Experimental evidence actually shows that more than 2 ml of the intraocular injections can cause a globe rupture. And it's more commonly seen in myopic patients with posterior staphylomas. So the diagnosis is a patient may complain of severe pain, a poking through sensation, sudden hypotony, hyphema, vitreous hemorrhage, poor or loss of red reflex improperly, and sudden increase in IOP is also associated in 10% of the cases. So if a direct globe injury is suspected, the operating surgeon should be consulted. It's better to postpone surgery. Urgent retina evaluation is mandatory and indentation of the retina should be avoided. It's better to pressure patch the eye with antibiotics and mydriatic drops, and a patient can be started on topical steroids, and if required, oral steroids can also be given. Further evaluation, it's better to be scheduled after 24 hours, and anterior segment evaluation generally will show any kind of hemorrhage. So this was a case of basically lid block where there was a perforation, and there was surrounding area of chemosis, and there was also a small vitreous tag which was present. This patient was managed with just a simple laser to the retina. The management depends upon the media clarity. The site of injury is of utmost importance for management and prognosis. Cases involving retinal tears only with minimal vitreous hemorrhage should be managed with just laser photocoagulation, either cryotherapy. And in some of the literature, they've just advocated observation, but I would recommend doing lasers to those breaks. Retinal tears associated with localized detachments can also be treated with laser photocoagulations. And posterior retinal detachments and tears should be taken up for earlier surgery because they can lead to PVR changes. So this was an in-house case where we had one injury to a penetrating injury in the supranasal quadrant with a whitening of the retina and a small subretinal fluid. The patient was managed conservatively, just a simple laser around the perforating injury was done. And the patient is doing absolutely well at this point. Retinal breaks can also present with subretinal heme. So there was one more case where on first post-op day, the patient presented with a subretinal hemorrhage. And here we had done a fundus fluorescein angiography to rule out any other causes of subretinal hemorrhages and to rule out mainly PCV. And the patient was noted to have a clear-cut area of penetrating injury where laser was performed, and the patient is doing absolutely well at this point. Massive vitreous hemorrhages with no view of the retina are generally, ultrasonography is the most important thing which should be performed, and that gives information about the retina vitreous. This was a case of a globe perforation where the patient has entry and exit wound with vitreous hemorrhages, retinal detachment, and the patient was treated with early vitrectomy and with endolaser and silicone oil injection. Surgical decision making also depends on the globe hypotony. If the globe is hypotenuse, then it's potentially devastating to do any kind of retinal surgeries. It's always better to wait for the intraocular pressure to build up. So oral steroids should be given, and once the pressure is built up, retina surgery should be performed. So my indications of surgery would be retinal detachment with large breaks, multiple breaks, posterior retinal breaks, vitreous hemorrhages with detachment, detachment with proliferative vitreoretinopathy, retina and vitreous incarceration in the injury site, perforation with an entry and an exit wound, endophthalmitis and scleral defects. Principle of management are not really different from that of a rhegmatogenous retinal detachment. Early surgery and any kind of vitreous disturbances should be treated earlier. So a pars plana vitrectomy with fluid gas exchange, endolaser should be the main treatment of choice. I have one small video where there's a 23 gauge pars plana vitrectomy where first the clearing of the vitreous and the vitreous hemorrhage is done. It's extremely important that the vitreous which is around the area of the wound is cleared thoroughly. This was a high myopic patient with a posterior staphyloma who had two small perforations very close to the posterior pole, and so after clearing the vitreous, fluid gas exchange is performed, which will flatten the breaks, and endolaser is performed around these breaks. Eventually, it's better to put a silicone oil tamponade to attach the retina so that we can give the best, especially in myopic patients where we expect that the retinal attachment may not be very good. So in these patients, it's better to put silicone oil rather than any kind of perfluorocarbonate gases. So just a laser which is performed around the breaks, and after that injection of the silicone oil for tamponade. So the take-home message would be that it's a serious complication of orbital anesthesia, and early recognition is extremely important. Preoperative assessment in terms of axial length, presence of any kind of staphylomas, areas of scleral thinning has to be noted. Any kind of bony socket abnormalities also needs to be noted. A good patient preparation, discussing the procedure and anxiolytics if required. Shorter needles, minimizing the number of injections, using of blunt needles, noting the negative aspiration before injection, and wiggling the needle before the injections are also recommended. Any serious complications are avoided if the patient is looking in the primary case. This was something that I found of very importance. Any kind of unusually soft globe congenital hemorrhages should increase a suspicion of a perforation, and early diagnosis and prompt management are recommended. Okay, thank you.
Thank you, Dr. Chinmay. That was very well presented. You did a good job of covering both ophthalmologic and anesthetic aspects of glow perforations, and nice video demonstrations of practical case scenarios. So I would like to invite on stage our next speaker, Associate Professor Oya Yalcin-Kok. We already had a very interesting talk by her in the morning on ophthalmic pain and treatment modalities. So, Madam is an Associate Professor of Anesthesiologist at Baskent University School of Medicine, Pain Medicine Lecturer at Baskent University Healthcare, Vocational College for Anesthesia Technicians. Her areas of interest are ophthalmic anesthesia, regional anesthesia techniques, acute and chronic pain management. She's published 20 national and 41 international papers. Today, she's talking about obstructive sleep apnea, ophthalmic anesthesia perspectives. So please join me in welcoming Associate Professor Oya. Over to you, madam.
Thank you very much for your kind invitation and introduction. Good afternoon. I will just talk about obstructive sleep apnea syndrome and its ophthalmic anesthesia perspective. I would like to start with, excuse me, can I just see one slide once? Thank you very much. I will start with the definition and I will explain which aspects that we have to suspect and evaluate and manage. And there's interestingly associated ophthalmic disorders with obstructive sleep apnea. I will just try to give a little bit insight about them too. To start with the description, obstructive sleep apnea is a pause of breathing due to obstruction of upper airway during sleep. But it must be at least for 10 seconds or 4-5 apnea or hypopnea periods for an hour. So the prevalence is actually high, is 5% of adult population, and 80% of these patients go undiagnosed before the surgery. However, we know that a strongly associated risk factor is obesity. What happens when obstructive sleep apnea we see in a patient? Actually, all the possible consequences are pathophysiological consequences when you stop breathing. Hypoxemia, hypercarbia, activation of sympathetic nervous system. And when you ask the patient, they have got daytime drowsiness, it means that obstructive sleep apnea affects all body systems, ending up with hypertension, diabetes, cardiovascular disease, and stroke, even with death. And we go with the population of ophthalmic anesthesia. Unfortunately, they are not exempt from OSA. These patients also require preoperative screening, intraoperative tailoring of anesthetic management, and attentive postoperative care to avoid possible catastrophic events. So the patient is there, whom to suspect? We will ask questions and maybe we will just see the physical situation of the patient. If they are obese, male, if they complain of daytime drowsiness, headaches, and attention deficiency, we will start to suspect of OSA. And if they are smoking and they have got alcohol or opioid analgesic use, they have got hypertension, diabetes, and metabolic syndrome, our suspicions get severe, and we will know that typical adult OSA patients snore loudly, and they often have witness apnea periods by their relatives or partners. So what will we do? We have to evaluate it. We have to have checklists or questionnaires. Among these tools, Stop Bank questionnaire has got the higher sensitivity. It evaluates data about the patient's physical and historical characteristics. And with the high scores of Stop Bank questionnaire, it means that your patient has got associated greater probability of moderate or severe OSA. And it can predict intraoperative, early and postoperative adverse events. So how we do it? It's very simple. We have got 8 questions. 4 of them, just you can ask, do you snore? Do you feel tired in daytime? Has anyone observed you stop breathing or choking, gasping during your sleep? Or do you have, or being treated for high blood pressure? And you can also see body mass index of the patient and the age of the patient, neck size, and the gender, if it's male. The scoring will be yes. How do we score? If there's 2 yes answers, or 0 to 2 yes answers, low risk, we see low risk. However, if it is 3 to 4 to questions, we have got yes, we will think that the patient has got a moderate risk to have OSA. And if it is more than 5 questions, or the patient has got bank questions positive, then the patient has got high risk of having OSA. But this is not only the way that we evaluate OSA. There are some supporting evidence like modified myelopathy score, or a new tool like drug-induced sleep endoscopy. We induce drugs. We give anesthetic drugs to induce sleep in patients, and otolaryngologists make a sleep endoscopy. Plus, focus of point of care ultrasound is another tool now to validate OSA screening. However, what we find from the literature, that there's no OSA screening tool validation in ophthalmic population, and no OSA study in ophthalmic surgery population yet, to my knowledge. What we concern about the anesthetic management in these patients are more prone to perioperative complications such as hypoxemia or cardiac arrhythmias. Unfortunately, they are also more prone to post-operative delirium and for reintubation or non-invasive ventilation support after the operation. What is the problem? The problem is whatever we give, sedation or general anesthesia, actually mimic the effect of physiological sleep. The physiological sleep is the real problem for these patients because it depresses the activity of airway opening muscles and increase tendency to airway collapse. So we start a catastrophic event going after the also in the perioperative periods. So we have to tailor the intraoperative management if we suspect or if we do know the patient has got OSA. What we recommend is regional or topical ophthalmic anesthesia without sedation. These patients may be assured by hand holding or vocal support during surgery, and we can use a semi-upright positioning which will help patients suffer from obesity. The problem with the sedation in OSA patients with any sedative at any dose unexpectedly end up with deep sedation. And then exaggerated relaxation in the upper airway, blunted central nervous system reactivity. At the end, unintentional movements, hypertensive response, and increased intraocular pressure can be a big problem in these patients. What we do, generally, we titrate the sedative. Timely convert to general anesthesia to ensure safe airway management and prevent snoring, unintentional movements, and IOP rise. If we look at the literature, the choice of sedatives are on the balance of alpha-2 adrenergic agents like clonidine or dexmedetomidine. The papers are saying that they are suitable agents, they are effective alternative, they are superior than midazolam. However, there are some controversial papers too that they are not even superior to inhalational anesthetics. Another recommendation is to use of propofol and remifentanil infusion for sedative reasons and keeping the patient spontaneously breathing during the operation. If we go with the general anesthesia, general considerations that we have to have is identify these patients with an arm band and prepare for difficult airway using 25 degrees head-up position, and if necessary, invasive monitoring of hemodynamic and respiratory functions, and extubation while monitoring residual muscle relaxation and consciousness. If we compare total intravenous anesthesia and inhalation, a recent paper tells that neither of them worsens the incidence of post-operative obstructive hypoxemic events. However, none of them was also superior to the other one. For opioids, opioids are the only drugs that should be avoided in OSA patients, both intraoperatively and post-operatively. For this, what we use the opioids for during the ophthalmic surgeries, mostly for the post-operative pain relief. However, the initial 24 hours after opioid administration, it is the most critical period for OSA patients to have a life-threatening opioid-induced respiratory depression. So we can swap these opioids with more practical, maybe safer agents like ketamine, lidocaine, alpha-2 adrenergic agents. And in the multimodal analgesia plan, we can also use some drugs like paracetamol, dexamethasone, and sometimes anticonvulsant agents. So for the postoperative care, what we do is we closely monitor these patients at least for 3 hours for oxygen desaturation, and we use continuous pulse oximetry. And the new paper especially recommends us to use capnography monitoring after the operation in these patients to make a best practice performance in these patients. Another problem is using oxygen. We will set the oxygen less than 2 liters per minute because these patients are so prone to have suppression of central hypoxia response. So we will let them have less oxygen than 2 liters per minute, and we will use a lateral positioning of 30 degrees or 30 degrees upright sitting. And if we are not sure about the patient's respiratory problems, if they are persisting, or the patients have to take opioid analgesics, an overnight admittance will be better than sending them in an ambulatory environment. And the PAP, positive airway pressure devices, are generally patients their own device, and we encourage them to take these devices to the hospital and use them as soon as they are awake and appropriate. The most important thing is that in these patients, apneic episodes are more frequent after the second night when they go back to their normal sleep routine. And just to say a little bit about pediatric patients, prevalence of OSA is higher in obese children, and these are a little bit different than adult patients. They don't have daytime drowsiness. They have noisy, paradoxical mouth breathing and nocturnal sweating instead. They have a common etiology, but for screening, we do not use top bank questionnaire. We use I'm sleepy questionnaire for these children. And to talk about the ophthalmic disorders associated with obstructive sleep apnea, these patients have higher intraocular pressure, and they mostly have primary open-angle glaucoma, and they have papillary edema. And what they have seen that glaucoma patients with progressing neuropathy, regardless of IOP regulation, mostly had OSA, and OSA should be suspected and treated in these patients. Another group of patients are keratoconus patients. They are usually young patients, and interestingly, they have higher prevalence of OSA and higher risk to develop or to be diagnosed with OSA. It is a non-inflammatory disorder, but they also lack with the respiratory integrity. The other group is that we will suspect, and in most cases they have got OSA with their problem, is eyelid laxity. They are middle-aged, obese men mostly, and they have a surgical correction as a day case, but disorder can be reversed by the treatment of OSA. It is reported in recent papers. The other problem with ophthalmic disorders associated with obstructive sleep apnea is they have got irregular oculomotility test evaluation. It means that in the post-operative period, they can have more symptoms like vertigo in the post-operative care unit. And whatever, the one interesting thing is the PAP devices that the patients use sometimes complicate the condition of ophthalmic surgery patients. For example, following bilateral placement of Jones tubes, and dryness and excessive tearing can happen after the use of these devices. So what to take home? This is a common problem now. We can use stop bank questionnaires to suspect, and we should avoid sedatives due to unexpected deep sedation, and we will avoid opioids, and we will monitor these patients at least 3 hours post-operatively. As a conclusion, this is a problem that increases perioperative complications. So if we have attentive anesthetic care, the safety part will be in balance. I was a little bit hurrying, but for further reading, I can recommend you the paper that we wrote with my distinguished author friends, and I would like to thank you.
Thank you for the very informative and elaborate talk on obstructive sleep apnea. So next I would like to re-invite on stage Dr. Tom Eek, consultant ophthalmologist, Norfolk and Norwich University. His topic for the day is various positioning of patients for cataract surgery who can't lie down flat. So waiting for the topic, sir.
Lovely, thank you. Thanks again for inviting me, and thanks for a fabulous lunch. I really enjoyed that. So I'm going to talk about positioning for people who really can't lie flat. So I've got some learning objectives. Simple adjustments to allow cataract surgery in most of your patients who can't lie flat. And then tips and tricks for the really extreme ones. Simple technique for the claustrophobic patient. Well, I showed you that earlier on. And just to remind the surgeons, look after your own back, okay? Because slip disc in the neck is the very common problem, occupational hazard for ophthalmologists. So they say you should lie flat for cataract surgery, but this patient can't. So what do we do for him? He's not a good airway for a general anesthetic. There's no other surgical thing we can do, so we leave him alone, or we do it with a local with very careful positioning. And there are 3 main groups of patients who can't lie flat, 3 main reasons, either because you can't lie flat because of your chest, because you've got bad heart, bad lungs, bad muscles, or because of the spine, or actually combination of the 2 does seem in my practice to be the most common. And a lot of these patients have a lot of anxiety, and they're also claustrophobic as well. So of the 3 groups, this is the first one. The simplest way to do these patients is to have them sitting up and have their head back so that their head is pointing towards the ceiling. And Mansour wrote about this about 15 years ago, pointed out it's actually very useful for the obese patients, of which we all have a lot nowadays. The reason being that if you have the eyeball at the top, you don't get so much vitreous bulge, so the surgery is a lot easier. So here's a slim patient. The center of gravity is below the eye, no vitreous bulge. This is an obese patient with a center of gravity above the eye, so all of that pressure of gravity gives you vitreous bulge, difficult surgery, whereas if the patient's sitting up, the center of gravity below the eye, no vitreous bulge. So it's more comfortable for the patients as well as more comfortable for the surgeon, and we can get the patients more comfortable still with pillows, gel pads, moving the headrest, etc., on your adjustable chair. So here's the second group. Those, it's just the spine, and if they're fit and well, then you can just tip the patient upside down, Trendelenburg position. And there's some nice cases in the literature. This is one from Kevin Miller in the States with one of his patients. And he's balanced this patient on, I think it's 11 pillows in this case. But you'll see that the eye is not at the top. And I saw Kevin at a conference and asked him about this. And he said, yes, indeed, I do get a lot of bulgy eye. I have to have the bottle very high, so the eye's being pushed back, forward from behind, and I'm squashing it back with the high bottle height. And he says it's difficult. So I try to have the eye at the top, so the eye's not so bulgy, and if you don't have a block, then again the eye's less bulgy because you haven't got that anaesthetic pushing forward. So this seems to be the commonest where they've actually got both problems. They can't lie flat and they can't extend their neck. And these are the patients, I showed you this picture this morning of the face-to-face upright seated positioning, where the patient is, well, hopefully not too upright, hopefully they're back a bit. The surgeon is facing the patient, sitting, standing, and the microscope is rotated forward, so I've moved the microscope forward to face towards the patient. And of course I have to do the cataract operation through the lower half of the cornea, not through the upper half of the cornea. And if we do it with topical intracameral, then they can have the eye pointing at the light, as I was saying this morning. So here are a few cases. I'll just skip through them quickly. They're all different. This is the open drapes for claustrophobia. I think I showed you that one this morning. We've had a 100% success rate with that one. All the patients said they'd be quite happy to have that again, and they would not have got on with the paper drape with a hole torn in it. So we did a case series back in 2011. We had 32 patients. This was just a patient who volunteered to have his photographs taken. Ankylosing spondylitis. This is him with the Trendelenburg. This is the view, if you can see there, from the foot end here. And I'm leaning in a little bit. I'm not very comfortable. And in retrospect, if I'd done it again, I'd have just turned the whole patient sideways. He was very, very rigid. But perhaps if we'd just turned him a little bit, or actually this way, wouldn't it? It would have been a bit easier for me, because I'm not looking after my back all that well there. We've now done a bigger case series. I'm now on about 300, but by 2017 we got 240, so we published them in the Journal of Cataract Refractive Surgery. There it is. And this is the headline figures. Okay, so of those 240 that we did, how many did I finish? All of them. Okay, 2 of them had to be rescheduled because they kind of got a bit panicky, and I don't always have an anaesthetist, so they had to come back with the anaesthetist for sedation. But 100% of them got finished. 100% of them got their posterior chamber lens implant, but that's a pretty high rate of posterior capsule rupture that we would hope to have under 2% in the UK, and my standard rate's under 1%. So yes, they are difficult cases, and I did drop 2 nuclei, and I've got a very good vitreoretinal colleague who was able to fish out the nuclei in these patients, but it wasn't easy for him. How many of them had medical complications, any intervention by an anaesthetist or calling a team or anything? None at all. Okay. So how many patients in that time did I actually say, well, look, this is just too difficult, and we're not even going to do it, I'm sorry? None, and it's still none. So the system works, okay? But we warn the patients that, yes, you're more likely to have a surgical complication. You're probably at least double the rate of surgical complications, and there's always that chance of some bad complication and the eye ending up a lot worse. Normally we say 1 in 1,000, perhaps it's more like 2 in 1,000. And if I drop the nucleus, maybe my VR colleague might not be able to fish it out. So I thought you'd like to see some of the more extreme cases. This guy, I can't remember what he had wrong with him, but this was as far back as we could get him. This is the chair as far forward as it will go, with the headrest as far forward as it will go, and 3 gel pads there. And this is me trying to work out whether I'm better off standing or sitting, and I was more comfortable sitting for him. This guy, long story, couldn't get out of his wheelchair, so we had to take the headrest from our own chair, put it behind him, put a pillow there. So these very, very upright patients, if they've got a big tummy as well, it's difficult to do the phacoemulsification this way round, because you're trying to phaco like this, and the tummy's in the way. So actually it's easier to phaco like this. And sometimes because they're very upright and they're old, the lid tends to droop, so either you need a big speculum to wind it open, or you just find, sometimes I'm holding the speculum and doing an underhand phaco, which is actually, it sounds tricky, but it's actually much easier than doing it the other way around. So this is me looking very relaxed here, you see, so comfortable. position. Comfortable spine anyway. So this is, I've shown you this one already. So we had to do everything with him. We had the Trendelenburg. We had to put a block under his chin because his chin kept going down. And he was another one of the underhand phacos with the speculum held up in the other hand. Another chap here, he was sent a long way. He did need a hoist to transfer to the chair, but his hoist sling didn't fit with our hoist. So we ended up tipping his wheelchair back. We took the headrest off our chair so that he could have his head back, and he's in a pretty good position there now, isn't he? He's like position 1, really, isn't he? So so he was straightforward. And actually, patients in wheelchairs, often it's easy just to do them in their own wheelchair. So this is the guy who was in the JCRS article. So this is just showing the position that we had him in. So this is with this. We just showed the position afterwards, but this was me doing the operation, and then we just took the photograph afterwards to show the position. This is him again. So you're all inspired. You all want to do this now. So what do you need? You need not much. You need a chair that reclines. You need the surgeon to be comfortable with the chair. You need a microscope that rotates forward, and the eyepieces that will then allow you to look through the microscope. So these are the chairs that we have. They're standard chairs in the United Kingdom. We've now got this Brumaba chair, which is very nice. And I love this surgical chair because it's small, and I can adjust it very easily just with the foot pedal there, go up and down, and I can move about and get myself comfortable during the surgery. And it's small enough to get really close to the patient for those really sitting up patients. The microscope needs to be able to rotate forward, and you'll see along here with the standard eyepieces, they only go up that far. So the shorter eyepieces go up a lot more, which means that my arms aren't so outstretched. But if you have a different microscope which is shorter, or you just take these pieces out, which, dare I say it, the vitreoretinal colleagues want, but we don't. So you can take those out, take out the assistant side pieces. So rather than operate like that, I'm operating like this with my elbows by my side, which is far more comfortable than trying to do that. Okay, so shoulder girdle, comfortable, operate with the fine muscles of your hand. So there we are, microscope rotated forward, short eyepieces rotated upwards, take out those extra bits if you can, and it's much, much more ergonomic. So this is the surgeon's view onto the patient. So this is the checklist. Well, you need a confident surgeon who's happy to do topical anaesthetic, happy to stand up, move around the patient, the chair that moves, the small wheeled surgeon's chair, lots of pillows, gel pads, cushions, wedges, the microscope that goes forward with those short eyepieces, which are actually the cheapest eyepieces that come with the microscope anyway. You need a good team who don't get stressed. The patient needs to be warned, obviously monitoring for the anaesthetist, and just be prepared to do things differently. Okay? And I always say all suggestions gratefully received for every patient because they're all different. The actual surgical technique, the only real difference is, the eyeball's round, you're just coming at it from a comfortable position, which will be the lower half of the cornea. Because the patient isn't lying flat, their head is here, then we put the bottle height higher on the machine. And normally I try to operate on the steep axis of astigmatism, but to be honest, I'd rather just get the cataract out safely than worry about the astigmatism too much. I talked about the speculum. The standard wire speculum is sometimes a bit too short, so this Clark speculum at the bottom here will wind up and be very open, or you can pull the eye up with that Jaff speculum. It's difficult for the nurses sometimes just to even put some saline on the cornea because they can't reach round, so I just put viscoelastic on the cornea to save the nurses the stress of doing that. And sometimes if it's difficult, rather than use my phaco chopper, I just use a straight stick for the phaco. If I get a bit stressed out, then I can just take the thing out. Rather than using bimanual irrigation aspiration, sometimes it's easiest just to use one-handed with the coaxial, which was when I did this week. Emergencies happen during surgery. One of the reasons I went into ophthalmology was to never be in charge of a medical emergency, but occasionally they do happen, and you're supposed to lie the patient down flat, aren't you? But these patients can't lie flat. So according to my colleagues, there's a little bit of evidence, a guideline about what to do with the neurosurgical patients who are sitting up. Basically change the position. This is what I've been told. And we did have one patient who was a group 1 patient with the standing temporal, who actually it just turned out to be a vasovagal because he hadn't told us that he was claustrophobic at the pre-op assessment, and he just got very panicky, and anyway, it was all right in the end, but I was glad I'd been advised, well, just move, change their position, and we sat him forward, and he stopped panicking. So face-to-face surgery, the safest option for a small minority of patients, only use it when strictly necessary. The patient sits up comfortably, the surgeon sits or stands facing the patient comfortably. Rotate the microscope forward, think about having a face turned, chin up, rotate the whole patient, etc. Pillows, pads, wedges, etc. And these ones, I would not want to have a block with these. I want the eye, you get them as close as possible to point to the microscope, but topical anesthetic just does that fine tuning and has the eye actually looking where I want it to look. Corneal incision through the lower half, bottle very high. I've got 2 minutes, yeah. And operating on. So turn on that short. I've seen for BR surgery, TV camera, to watch it on the screen. He emailed me, the blue-eyed sales representative, scope, and we turned it 90 degrees, then otherwise I'd have been like that. So, so there's me smiling. So, so the three ways, so distal and medical complications, that makes life a lot easier.
Sir is the instructor for various AHA workshops, coordinator in India. He's a regional faculty for AHA in BLS, ACLS, PALS, faculty for WFSA courses in obstetric anesthesia and pediatric anesthesia in India. So, sir's topic today is brainstem anesthesia. So please join me in welcoming Dr. Raja Narsingh Rao on stage. Over to you, sir.
Thank you for the introduction. First of all, let me thank the organizers for inviting me for this as a faculty. Sure. Let me thank the organizers for inviting me for this presentation on brainstem anesthesia. I work with the organization, and my greetings from L.V. Prasad Eye Institute, which is one of the tertiary care centers, one of the biggest tertiary care centers in the country. Now, today I will be talking about brainstem anesthesia, but I just want to present some of the case scenarios which really happened to us in a period of 12 months. And two of the patients had happened to me personally. So I thought I should give a case presentations and then talk about the topic of brainstem. A 64-year male with diabetic, ASA grade 2, normal vitals posted for cataract surgery. A peribulbar block was given and connected to the monitors. After 10 minutes, the team wanted to shift the patient. Normally in our scenarios, the technicians shift the patient to the OR. Wanted to shift the patient to the OR from pre-operative area where the block was given. The patient was completely unresponsive, but the monitors were showing heart rate of 86, blood pressure of 130 by 80, and the respiratory rate 26, and the saturations of 96%. So rapid response team was called, and even though, because he was in the theater complex, the anesthetists themselves has taken care of the patient, and they managed accordingly. So what do you think about this case? Coming to the second case scenario, a 58-year male, ASA grade 2, normal vital, posted for cataract surgery. A peribulbar block was given and connected to the monitor. And after 3 to 4 minutes, a patient stopped responding, vitals remaining normal. In view of the partial deafness, they shouted in the ears, calling her name, pinched her, but there was no response. This was managed by giving oxygen, IV cannula was put, emergency crash cart with intubation equipment brought near to the patient, and after 3 to 4 minutes, patient became conscious. Later, when asked, the patient said he did not know what happened after the block, and neither did she feel anyone touching her or calling out her name. So is it a brainstem anesthesia is the question here. The third case, a 49-year-old male, ASA grade 2, normal vital, which was posted for therapeutic PK. Peribulbar block was given and connected to the monitor. After 2 to 3 minutes, the patient had convulsions followed by loss of consciousness. Carotid pulse was absent. ECG slowly went into asystole, and after 4 minutes of CPR, patient regained consciousness and ECG showed normal cynicism. Again, is it a brainstem anesthesia is the question. The fourth case, a 53-year-old male, ASA grade 2, normal vital, which was posted for SOR. Peribulbar block was given and connected to the monitor. After 4 to 5 minutes, when the patient was about to be shifted to the ward, they found the patient unresponsive. Patient was lying, having bradycardia and was going into cardiac arrest, according to the technician who brought the patient. And the patient was not breathing at all. When the anesthetist doctor arrived, patient became completely unresponsive. Initially, bag mask ventilation with 100% oxygen was given, and as the saturations were not getting recorded. So as the saturations were not improving, immediate intubation was done and CPR was done. After 4 to 6 minutes of CPR, the patient started responding, and slowly the extubation was done. So is it a brace? All these 4 cases were happened in our, luckily they happened in our hospital complex, in the OR complex, and that was the reason why the anesthetists were in and around the place, they were able to manage. As we all know, brainstem is a structure which takes care of the heart. Any abnormality in the heart, it goes to the brainstem. Any abnormality in respiratory centers, it takes care, and other CNS, all the systems, and especially it consists of a lot of all these things are taken care of the mid-brace. So whenever this area is anesthetized, all the activities are lost. Now, regional anesthesia for ophthalmic surgeries, one is the topical, and talk much about the anesthesia component, retrobulbar, peribulbar, subtenon block. Complications particularly associated with the regional block anesthesia may be limited to the eye. It may be just limited to the eye, or it may be systemic. The eye complications include like chemosis, congenital hemorrhage, retrobulbar hemorrhage, global perforation, optic nerve damage, ptosis, and extraocular muscle damage. Allergic reactions from amide anesthesia commonly used for eye anesthesia, such as lidocaine and bupivacaine, are very rare, but there are reports of allergic reaction following the use of hyaluronidase mixed with local anesthetic agent. I don't know how many of the practicing people they had hyaluronidase, but we regularly had hyaluronidase to the local anesthetic, especially the bupivacaine and the propiocaine. Systemic complications. Anaphylaxis, that is anaphylactic reactions to the drug, injection or diffusion of drug into the orbital vasculature. So now coming to systemic complication, when you inject the drug may diffuse into the orbital vasculature or may be injected directly into the subarachnoid space. Anaphylaxis reactions to the drug manifest with immediate onset of rash, bronchospasm, as well as the persistent cardiovascular collapse. Now coming to the main brainstem anesthesia, central spread occurs if the needle tip has perforated the optic nerve sheath and if the injection is made into the subarachnoid space. Central spread may also occur on rare occasion if the orbital artery is cannulated with the needle tip and drug injected vascularly. The incidence of brainstem anesthesia, they say that the incidence occurrence could be as high as 0.8% when the retrobulbar blocks are performed with long needles. Incidence at 0.03% when peribulbar blocks are given. How do this spread into subarachnoid spaces? As you all know, that eye is developmentally a part of the brain. The optic nerves are extensions of the meningeal sheath covering it, and the cerebrospinal fluid communicates freely with the subarachnoid space around the nerve. Inadvertent puncture of the dura during the orbital block may lead to the drug injection beneath the sheath, leading to spread via the subarachnoid space and toxicity at the control centers in the brainstem. This is just to show the picture how it may travel through the nerves. Vascular spread, retrograde flow of anesthetic agent from the branch of the ophthalmic artery through the internal carotid artery to the midbrain can occur. This event induces immediate CNS symptoms such as respiratory arrest and hemodynamically changes. The classic clinical picture resulting from intra-arterial injection is, however, the immediate onset of seizures activity as a predominant sign. This is again a picture showing the branches of the vessels. Some research studies and demonstrations were done, and the contrast media, when injected near the nerve, it tracked proximally along the nerve to the optic chiasma, ultimately reaching the pons and the midbrain. Studies have shown that use of 25 mm needle were recommended. It is recommended that 25 millimeter needles afford greater protection against the optic sheath. Penetrating when 31 to 38 mm needle used, they reach the optic sheath and damage it. That's what I was asking Dr. Jay when he was presenting his this thing. He was using a very long needle, so I was asking whether he had any complications and all. He is very much used to that needle. Anyhow, that shows about the experience he has, and regularly he uses a long steel needle. Now, for this presentation, my take-home message is actually what we found out is it's not that even just an anesthetist should be well versed with the resuscitation or airway management and all. The people who are giving the block are people who are there. The ophthalmologist also should be little bit have some knowledge how to manage the airway temporarily until the help comes and all. And for our experience, we had many cases. I'm talking about the patients which we have landed up in problem in the main hospital. But we have many periphery centers where on and off we have lost the patients because they don't have any help. A single surgeon is there. They just give the block. And some of the places, and it happens in many of the institutes, they don't have the proper monitor also. They will be doing manual monitoring and all. And by the time they drape it and they do the surgery, and after, if it may be too late, by the time they realize that the patient has gone into brainstem anesthesia, the cardiac arrest and all. So this case underscores several important take-home messages. First, brainstem anesthesia remains a real hazard of regional ophthalmic blockage and may present with atypical features. Because we have seen it may be started with convulsions, it may be anything it may be atypical feature. The second, the latent period between the block and the symptomatology is variable and influenced by many factors, including the orbital anatomy, the volume of the local anesthetic, the rate of spread, and the constitution of the local anesthetic. Also, a prior history of the trauma, eye trauma or repeat surgeries raises the spectrum of possible intra-orbital scarring and anatomy aberrations. Third, the differential diagnosis should include other acute neurological or cardiovascular insults that produce similar symptomatology, especially cerebrovascular accident. The other thing is, the fourth take-home message is beneficial outcomes with no long-term sequelae are expected when assisted ventilation and intra-inotropic support are instituted in a timely manner. Finally, the temporal relationship between the performance of an eye block and the onset of neurological cardiovascular respiratory symptomology should raise suspicion of brainstem anesthesia. So these are some of the take-home messages. And another thing, what I feel is, especially the recent, the people who started giving the block, better they use a smaller size, smaller needles while giving the block, and less volume should be used. Observe the patient for at least 10 minutes after the block. Don't shift the patient immediately to the OR. And intra-operative monitoring is must. We have requested all our periphery centers now, after a request of more than 10 years, they now are implementing monitors in all the small centers also, so that anything happens immediately, they can recognize what damage has been done to the patient. These are some of the studies where case reports where they have written about the brainstem anesthesia. Thank you.
Thank you, sir. That was indeed an excellent potpourri of cases. So, sir has definitely defined our session. So, that brings us to the end of the potpourri session. So, I would like to invite the speakers on stage and over to the moderators for the tete-a-tete.
Thank you all. I have one question for Oya and one question for Tom. Oya, ladies first then. I quite often observe if I have a COPD patient, when they get sedation and they switch from nasal to oral breathing, quite often that is the point where I have the impression they're over-sedated. Maybe you know the data, you can comment on it. The question to Tom, do you think that with the propensity of our patients to be more and more obese, is there a new risk factor for suprachoroidal bleeding entering the scene? Maybe you and your vitreoretinal colleague can comment on it. Thank you.
Thank you very much for the question and your contribution. Yes, I haven't read anything about this from changing from nasal to oral expiration and inspiration as a publication. However, I can say that you're right about your observation, including my experience about this, because I believe that this is due to the excessive relaxation of these upper airway muscles. So this is just like small patients, pediatric patients with adenoid hypertrophy. They act like that, but this is just my comment. Thanks.
Thanks, Rudy. So the question was about obese patients maybe being at increased risk of choroidal hemorrhage on the table. And my guess is that if you have the patient very flat, then they're uncomfortable and they're sort of puffing and straining. If you've got a lot of the British surgeons will put just the paper drape over the top, and they're too arrogant to even cut a hole in the paper for the patient to breathe room air. So there's a lot of carbon dioxide accumulating under the drape, which is the vasodilator. And then the eye is very bulgy as well. So the moment you open the eye, then the intraocular pressure goes down to zero, and then you're trying to repressurize it, and you're doing like Dr. Miller, you put the bottle up high, so the intraocular pressure is bouncing up and down as you take the instruments out to change to irrigation aspiration. So my guess is probably you're right, it probably is an increased risk of intraoperative choroidal hemorrhage, which is a bad thing. I mean, it used to cause expulsive hemorrhage and loss of the eye when we did open cataract surgery. Now with small incision phaco, usually the patient doesn't have any permanent loss of vision, but it's very tricky and it's certainly sight-threatening. But VR comment, please.
So not just with obesity, but what I've noticed is that if the patients have a very short neck, that affects more. And second thing would be in VR, it doesn't really help. I mean, doesn't really make much difference because we have our own infusion cannulas and we maintain a pressure at a certain level. But when we're finishing the surgery and when we have either a fluid gas exchange where there's air inside the vitreous cavity, or if you have silicone oil, that's when it affects. So that's when we do find choroidal detachments and choroidal hemorrhages coming up, especially in obese patients. So what I saw for Dr. Tom's talk was that maybe it's really useful to have a table which kind of reduces the intrathoracic pressure and everything coming up. So that can be, I think, used late. Yeah.
We did a little study. We asked we got our patients flat on the chair. I didn't have time to tell you, and said, "Would you like to sit up a little bit?" And 27% of them said, "No, I'm fine." All the rest wanted to sit up a little bit, okay, and 10% of them wanted to sit up at least 30 degrees. Okay, so that's just asking just standard cataract patients, would you prefer to be a bit more upright?
We have seen that introducing a sharp needle blindly into the eye is dangerous. So, can we have alternative approaches like putting an ultrasound probe in line with the needle, with the patient closing the eyelid? Can it help the direction and placement of fluid, avoiding complications? Ultrasound guided block.
I've got the thing in my hand, so I'll say we'll just use a blunt cannula subtenon, and then you're avoiding nearly all of the risks of needle block. I saw somebody show a video of doing ultrasound guided block, and he had the ultrasound. You could see the eye. Yes, it's an eye. It's round. It hasn't got a staphyloma. He took the ultrasound away and then stuck the needle in, and then put the ultrasound back again. I said, "Oh, I haven't put it through the eyeball." And I thought, well, what's the point of that? So if you do it, I guess you should do it properly, but I should pass on to anaesthetist.
Actually, I should thank Dr. Tom Mackey because in 2017, when we had the 4th OFISACON, he made the similar type of presentation. And after that, we had 2 surgeries, and they belong to your second category, and the surgeries were performed very successfully. But after seeing his presentation, I felt that he was showing that the television through the 3D, that may be a better option in future, because what I found in that was there was no tough job for the anesthetist, because we gave the block that was not, but the surgeon had a high difficulty while operating. The position was so abnormal, like your friend, you named something, he was protruding, so she has to protrude and forward and do the surgery. But I think that TV, 3D and whatever you are showing, that may be a better option for surgeries.
So brainstem anesthesia is really scary. What monitors do you recommend when you give the block? And do you have an IV cannula for cataract surgeries?
Okay, sir. So actually, that is a good question, which many of the presentation they ask. Whenever they say that for not leave off about cataract surgery or for everything, I always prefer minimum 3 paramonitors. One is the ECG, one is the SpO2, and another is the NIBP. Okay, even I think we are not practicing that. Of course, now we are practicing. Before we are not practicing. Like when we are giving the block also, we keep this NIBP, SpO2 and ECG. So when you are giving the block, immediately you will be able to know that. That's what I think. Any suggestion by somebody else? Because many of them, they say only SpO2 is enough. But I say that ECG is also very, very useful, because something goes with the heart. It starts there, and then the SpO2 will be at a later level what you see. I think ECG is also very much essential.
And then for cataract surgeries, we use less volume. For VR surgeries, we usually give 6 to 8 ml. Is it wise to split the dose and give rather than have a single shot injection?
I don't accept this for cataract surgery. I have seen some of the people, they give 12 ml, 14 ml also for cataract surgery. When they go and get the block, they give high volume. I think everybody sitting in this August hall should accept this. When they don't get the block, definitely they repeat it. And some of our senior colleagues, even in our hospital also, they give, I was telling you about the volume, even the bilateral block also they give for surgery. So don't think that just if it is a cataract surgery, they will give only 4 ml.
Okay, if it is still high volume, don't you think we should split it and stagger the dose rather than give it at one shot?
Precautions are precautions. You should have all the precautions. But even after taking precautions, anything can happen. Even with the 3 ml dose also, you may inject into the vasculature, and then you may cause brainstem anesthesia.
Sir.
Sir, Dr. Ashish Diwan, he wants to...
Like the IV cannula, it's very, very imperative that any procedure done for ophthalmology procedure has to have an IV line before any procedure is started. Be it a cataract, be it a small surgery, whatever is required, an IV line is a must because it saves you during many conditions. And regarding the use of dosages, it depends on the type of block which you have given. The amount of volume depends on the initial volume which you give. With the 6 ml, you are able to find out of the 4 ml that is a good echinacea and analgesia. Then there's no need of giving anything more. In fact, they say an infralateral block plus a medial conal should be sufficient to give, and a volume of 4 to 6 ml should be sufficient. People,
VR surgeries, we need to give more for...
VR surgeries, you could go beyond the plane, that is equator, and then deposit 6 ml. Around 10 ml should be sufficient enough. And if there's any issues, the surgeon could supplement it by subtenon. But sedation is a must. And monitoring basically any procedure, be it for an injection also, or before giving the block also, and ECG, blood pressure, and the heart rate rhythm, and saturation is very important. The last thing which he said was the patient should be observed for 10 minutes. I would say it's for 10 to 15 minutes, but should be observed by the person who has given the block, rather than telling it over to the other person to see, I have given the block, I am going. And the person who is giving the block should be good enough to resuscitate the patient when something is happening, and not to say that, well, just I have given the block, what would happen? It would happen once in 1,000. And as he said, unless the person is adept at doing it. And if an ophthalmologist does it, I am quite sure that As somebody said, Dr. Ganesh said, his CPR technique would be rusty at these times. It's not the question of being rusty. It's somebody who should be present to resuscitate. If you are quiet, they would ask you, what are you doing sitting down? But if things do happen, you have to be present there to do what is required. Thank you.
Actually, I wanted to ask Dr. Suman, she was telling that she's a NABH. You do a lot of pediatric surgeries. Do the NABH recommend that whoever is doing a lot of pediatric surgery should have a minimum amount of participants, or the doctors who should do pulse or any pediatric resuscitation program?
See, the standards basically say that you have to follow certain established evidence-based guidelines. So it's not prescriptive as to say they should have PALS or that. Basically, whatever you follow, there should be a national guideline or a society guideline which tells you what to do. So NABH doesn't say, this is 1, 2, 3, this has to be done, that has to be done. Whatever you do, if you support whatever you do with evidence, that is accepted.
Yeah, even PALS and Indian resuscitation, pediatric resuscitation.
Whatever anesthesia society says, NABH will accept. So that's fine.
And one more thing I just wanted to answer is IV cannula. Very recently, we had a surgery of one of the very senior anesthetists. I think I can name her also, Dr. Manimala Rao. She's a very powerful. She came to our hospital. She had a glaucoma, some glaucoma surgery. Glaucoma surgeon has done it. And they did the surgery. And she, of course, was high risk. And next day, she called the director of our hospital. And she said that, wonderful, your anesthetists are doing even for high-risk patients also, they are not putting a IV cannula. So that is the remark they passed. So that is the reason I should say that for every patient, we were normally for high-risk patients, we put IV cannula, but I think as Dr. Jagdish says, for every patient it's better to put a monitor, and also we don't know which patient goes bad.
I think for the sake of time, last question.
No, comment.
Okay, last comment.
Just one thing is the IV line, which he already mentioned. Since 86 onwards, I have not done any case without IV line to any patient. But the moment about the monitoring, I want to make a comment was the fourth monitor is, I do not heavily sedate at this stage, but keep communicating with the patient for 10 minutes. That's very, very important that you can pick up why you stop talking. And that's, you should have all these 3 monitors you mentioned, but the 4th monitor for us. But sometimes we are single-handed with the patient in the pre-operative room. So please keep communicating with the patient.
So one question to you, sir. Even with topical cases, okay, topical cases, what do you still put IV line? Topical
Of course, IV line. Not done any case means any case. Topical also IV line.
Madam, actually there is a norm that especially in a pediatric patient, when you are giving IM, you should have an IV. So that is the normal thing what they say. But anyhow, we do pediatric patients without IV cannula.
Last quote, sir. As somebody said, you said who does, as a pediatric anesthetist, basically a person should do at least around 6 to 10 cases every month, less than 2 years, to be called as, rather than NABH trying to say, well, whether you are in the pediatric. PALS course, anybody could do it. A person who has done ACLS and was worked in anesthesia could well manage a PALS at that time, trying to do ventilation and then giving some massage and starting an IV line. But doing the case, pediatric case as such, unless the person is experienced and doing routinely every month. In fact, there's a book on none which says that when do you call a person as a pediatric anesthesiologist, as to how many cases should we do on rotation, that to call yourself, to qualify yourself subsequently also. Thank you.
Okay, so that brings us to an end of this session. So I would like to request Dr. Kannan and Dr. Alfred Chua to please come on stage to present the mementos to our speakers. Dr. Kannan, I would like to request you to present the memento to Dr. Chinmay Vyas. Dr. Alfred Chua. I would request you to present the memento to Dr. Raja Narsingh Rao. I would request Dr. Suman Shri to please come on stage to present the mementos to our moderators, Dr. Kannan and Dr. Alfred Chua. Dr. Alfred Chua. Thank you, speakers. Thank you, moderators. So I'll be now handing over the mic to my colleague, Dr. Dhwani, for the next session.
Good afternoon, everyone. It's been an interesting day so far, and we are inching towards the last academic session for today, which is on NABH eco standards and beyond. We at Netradhama have been the first eye hospital to have a NABH full standard accreditation since 2008, and in the current time, it has become a standard certification for all kinds of practices. So I would like to invite our moderators for this session to take their seat. Dr. Murli Srinivasan, who's a consultant neurologist at Manipal Hospital, Bangalore. Dr. Suman Shri, CEO, Director, HOD of Anesthesia at Netradhama Super Specialty Eye Hospital. And Dr. Savita Arun, Director, Medical Superintendent and Senior Consultant Ophthalmologist at Netradhama Eye Hospital. For the first talk, I would like to call upon stage Dr. Murli Srinivasan, who's a consultant neurologist and Chief of Clinical Services at Manipal Hospital, Bangalore. He is going to talk on NABH eye care standards. Dr. Srinivasan was also associated with Christian Medical College, Vellore and Manipal College of Medical Sciences, Nepal. He has expertise in movement disorders, neurology and stroke. He's currently practicing at Manipal Hospital, Bangalore. I'll hand over the mic to you, sir. Now.
Good afternoon. Good afternoon. At the outset, I thank the organizers, Dr. Sri Ganesh and Dr. Suman, for giving us this opportunity. It's more than for me as an individual, it's, I think, an opportunity for NABH to probably let some of you know what this whole thing of eye care standard, how it evolved. Because many a times when we go to various forums, we also come across a lot of talks, what is the eye care standard, whether we should go for main standard, whether we should go for a eye care standard and so on and so forth. So the next 10 or 15 minutes is going to be essentially on two aspects, how this standard got evolved a bit of it, what does this standard contain, is it different from the main standard, and then also a few tips on how to cross the bridge or where are the hurdles. So I think with these few introduction, I will go into the main presentation. So when this came actually from the industry, saying that we would, because there are a lot of eye care institutions and a few, like as we know, Netradhama and a few others have gone for the main care standards. Many others have gone for a small healthcare standards. Then there was a representation saying that could we have a separate eye care standard which will address most of the requirements of an eye hospital, be it a small eye hospital which with just 1 or 2 daycare beds to a hospital which has full-fledged inpatient facilities and so on. So with this in mind, the eye care standards were prepared by a team of people. So essentially, if you see, it is based on the small healthcare standards plus a few additions. So small healthcare standard plus a few additions and a few modifications. The modifications mainly include for, say, a few things like air conditioning and a few things on, say, the minimum requirements for a registration to the organization and so on. So it is basically somewhere between the main standard and between the eye care, the small healthcare plus a few points. The chapters haven't changed. 5 patient-centric chapters, 5 management-centric chapters. So the chapters continue to be the same. So the chapters have been aligned with from the time the patient enters the organization till the time he is managed, his rights are protected, infection control, and the other 5 chapters are on management-centric. Now, as I said, I am going to talk here predominantly from what is it, if you are going for an assessment, what is it that the assessors will look for, and so as I said, how easy can you cross the bridge? So most of the time, they would not just look at the documentation, they would look at whether the intent is met. Intent of the standard, intent of the objective element, intent of the policies and procedures, and this is done by not just by looking at records, many a times also by witnessing an activity which happens within the organization. Most of the times it is sampling, so which means it's impossible to look at all records. So they may look at about 8 or 10 records for a particular thing, which the particular event or particular aspect which they are looking at, and based on that conclusions would be made. Now a few things, legal requirements will have to be met. Now what is legal? There are a whole bunch of things, but what NABH predominantly looks at is one, whether the healthcare facility is a legal entity. By meaning legal entity, whether you have a Clinical Establishment Act license or whether you have, if that is applicable in a particular state, if it is not applicable, whether you have a local corporation or a municipality, certificate, registration certificate, or with a health department, something to say that you are a legal entity as a hospital or as a eye care hospital. So that is what is looked at. Second, because of where the multiple incidents and also a part of patient safety, fire is one aspect which is looked at. Now we all understand, we all know that in a small healthcare organization or in an eye care, many a times where it is in one floor of an organization, of a building, it becomes difficult to get fire NOC. Now if you're not able to get NOC, there are guidelines which is made what you need to look at. Primarily the intention is that your patients who are coming there, they should be protected. So that's all. So always when this point is a little contentious, people are a little worried, but at the end of the day they don't realize this is also to protect their patients and themselves in case, God forbid, some incidents happen. So what normally is done is, there are sometimes old buildings where probably fire clearance is difficult, or they would have tried, it was not possible, and so on. So what the organization look for is a trail of events or a documentation saying that yes, this building, say, is 50-year-old and we have informed the fire authorities. They said we could not give, whatever, and we have done an independent audit. Based on this independent audit, these are all the things which we have done, and based on that the audit have come back and said that your staff are trained, you have all the equipment, and your patients are whatever safe. So they normally give a certificate. So that is what is looked at. In addition, you look at the Pollution Control Board and various other clinically relevant licenses within the organization. Of course, in addition, the assessor looks at the safety aspects at all levels, best practices, published guidelines. Someone was talking about, the previous speaker was talking about what was the NABH guidelines says about it. As Dr. Suman had rightly pointed out, it is not prescriptive. All it says is that you have to have an age-specific competency. Suppose you are giving anesthesia to newborns or kids, you should need to know how to tackle, so as someone said, it may not just be NALS or PALS training, but it was also how many times, how many cases which you have given. That is what the organization should use when they are credentialing them. So while NABH is not prescriptive, it gives an overall guideline, and it is for the organization to credential or privilege them based on some of these criteria. So typically during an assessment, there are multiple types of assessment. As an organization, they first go through the pre-assessment, then where mainly the assessor looks whether the hospital understands the standards, whether the documentation is in place, and then the legal aspects are in order. Then after that, there is a final assessment, which is more of a sampling exercise, staff awareness, various aspects of the standards are checked. And then in case, very rarely, there could be a verification assessment, and every hospital after around 1.5 years undergo a surveillance. So it's a pre-assessment, final assessment, after which the accreditation is given. Then there is verification is not common, maybe about 5% of the times there is a verification. Surveillance is at 1.5 years, and then there is a re-accreditation. Now, so many a times the problems is understanding the standards by the assessors and by the assessees. So the question always comes, everyone asks whether I should have a consultant, whether I should have someone to help me. If you ask me, the answer is no. The reason is, many a times your consultant will come, they will give you some documents or some things which they have developed for some other hospital, which may have no relevance not just to your hospital or to your processes. Somehow you will get that may not add value, and actually sometimes during the next cycle you may have probably more non-conformances and so on, and you would have paid a lot of money for that. So the best way is to train your people, understand it. Even though it is going to be a little rough, I think it's the best way is you yourself develop your own people to do the work. Now, guidebook is under preparation, and I think sooner the guidebook will be available, which will further help you to make understand these standards or help you in implementation. Now, a guidebook is not going to be something which will answer all your queries, but yes, definitely it's a guide, and definitely that is going to be helpful. Most of your doubts are will be addressed in the guidebook when it comes. Now, eye care standard, as we said, is primarily on small healthcare plus a few additions. Few additions we said about legal and some of the requirements on fire and so on. One more aspect is that it looks at is the air conditioning. So air conditioning, while you don't need a HEPA filter in the higher level of air conditioning, you would need a AHU at least. So window AC may not be sort of permittable for a eye care standard. Of course, maybe at a pre-entry level, that may be still be accepted at this point of time. But for an eye care, at least a AHU is needed. We'll, if there are doubts, we can discuss that during the question and answer session. So the key concerns in the standard, especially related to ECU, are predominantly Ophthal is an outpatient department and daycare. So, there has been measures taken to ensure that it is not like a complete hospital. The standard itself addresses this, and medication management, certain aspects, it is difficult to manage because it's a very small setup. So many standards, it may not be, some of them may not be relevant, but yes, why it is important is so that safety at every level is met. And of course, the other area, as we said, AHU is one aspect, and then of course is the reuse. So reuse, as an organization, you should have a policy, and that policy should be based on some documents which should be traceable. The other aspect, before I forget, is that most hospitals face a problem is in terms of having registered nurses. While we understand that in an ophthal practice, as a the organization NABH also understands that in an ophthal practice, many a times you may not need so many nurses like as other hospitals are needed, but at least a minimum number depending upon the volumes you would require. Or I'll put it this way, in ECO, even the smallest hospital would look for 2 registered nurses. RNRN is a term which is used. So they would at least look for 2 so that there is a continuous cover. Of course, we all there is an understanding that there are many others who are also involved, not just nurses, involved in the theatre and the care of optometrists and so on and so forth. The other concerns are ophthalm specific staff cadre, because there is not much of registration. Hopefully this government should implement some of these aspects so that they all get legitimized or little more legalized. The medical records, again, continuity between OP and IP. Many a times this is found lacking. So you would have seen the patient in the OPD, and then the patient comes to the comes for a cataract surgery. The link between the two is many a times found missing. Of course, medico-legal records is something which is very important in record keeping. Involvement in social responsibility and public, that is health, is in ROM. Most eye care institutions would have some way, or again this is part of the ISQA requirement, that is why this is there. Relevant key performance indicators is in CQI. So in key performance indicators is something which many organizations struggle, but don't worry, if there is a beginning and if it is done with true intent, I'm sure during the first cycle it is easily accepted, because when it comes to reaccreditation, they are always a little more stricter. So other areas which is touched upon in the standard is on communication. Someone had earlier talked about saying that communication during to the patient during the surgery is very important, especially in an ophthalm, so that you know what is happening. So that has been stressed. Organ transplant, green concepts, and of course on community ophthalmology. So now once you get accreditation, people go beyond accreditation. So what do you do there is to implement the standard with the pure spirit and intent, and then also look at quality and patient safety, and then which is part of everyone's job. It's not just the quality management team or only for the doctors or nurses, it's everyone's job. And then systems data is something which you should start capture, because only with that, I think there is also a couple of talks on clinical audit. That is going to be possible only when you are able to capture the data, and it has to be robust. Data analytics is a key to the next level, and then compete with self and industry benchmarks. So many a times we may not have benchmarks, but we will have to create our own, and also look at the industry for benchmarks. And also that accreditation is it's only a beginning of a journey, it's not the end. So that is something which has to go into all of our in the DNA as we go ahead. I think that's all I have in a brief 10-15 minute period. I think the questions are towards the end, right?
Have it at the end.
Yeah. Thank you very much for the patient listening. Hope that was nice.
Thank you, Dr. Murli Srinivasan, for that informative and practical guidelines for NABH. Veni Vidi Vici, that is a quote by Julius Caesar. Also, that is the title of our next talk by Dr. Savita Arun. Dr. Savita Arun is the director, medical superintendent, and senior ophthalmologist at Netradhama Eye Hospital. She is the QAC also at our hospital and principal of Netradhama School of Optometry. She has special interest in neuro-ophthalmology and electrophysiology, for which she's been trained at Germany. I hand over the stage to Dr. Savita Arun for her talk.
A very good evening. Thank you, Dr. Dwani. At the outset, I would like to thank Dr. Sumanshri for the opportunity. Veni Vidi Vici is a Latin adage popularly attributed to Julius Caesar after a quick victory and a short war. So today's topic is on how we did it, how we went about our quality journey, and how we got accredited for full standards. And we were the first eye hospital in India to be accredited for complete standards. In brief about the quality journey of Netradhama, we embarked on our quality journey 14 years back in pursuit of our vision to be a leader in eye care domain and a vision of vision care par excellence. Our quest to progressively adapt to meet the changing demands of public accountability, clinical effectiveness, and improvement of quality and safety we embarked on the accreditation process because we believe that accreditation process intends to change the way the system operates, the technical procedures of service delivery with appropriate use of technology, resources, integration of relevant knowledge in an effort to ensure social participation. Salient features of our quality journey were very few multi-speciality hospitals in India had NABH accreditation for full standards. That was 14 years back. And healthcare professionals and public awareness of accreditation was very less. And standalone hospitals like ours, an eye care organization, had to comply with complete hospital standards, and which was drafted for multi-speciality hospitals. We were wondering as to how to go about it. So we came to our destination. We knew what we had to achieve. That was our goal. And that was through seamless preparation to sail through the process of accreditation. We classified the challenges as program-related challenges and organization-related challenges. The program challenges were related to external factors, and the organizational challenges were internal factors. Program challenges were mainly the incentives. Strongest motivation for any eye care, for any hospital accreditation is continual supportive system from government and insurance agencies. All of you will agree with that. And accreditation marketing, introduction and highlighting the benefits of accreditation to public by government and insurance companies will help the consumers or the patients to make informed decision of the choice of hospital healthcare organization based on these criteria. And it would be more successful when the standards were relevant and more corroborative with the HCO. All these are taken care to a large extent now. Coming to organizational challenges. So the first challenge was interpretation of NABH standard and documentation to an eye care organization. And the objective elements which are there in the complete standards like nutritional assessment, single use of medical device, blood bank were not relevant to ECO. So the SOPs were made as a compliance to ISO, but they had to be modified as per the NABH requirements. And the WHO safety solutions that are there had to be customized to an eye care organization. All these were challenges. And we had to make a lot of infrastructural and facility changes to ensure patient safety. A lot of infrastructural changes like ramp was provided for wheelchair, fire exits and fire safety compliance, as Dr. Murali pointed out, we had to make that. Dedicated toilets for physically challenged, dedicated pediatric area and for nursing mothers, grab bars in the toilet. These are some of the examples. So we had to do away with the manual registration, and we had, in order to hasten the process of registration, and biometric system was introduced with photo ID for patient identification. All these were as a part of our compliance. And coming to the third organizational challenge, that was the operation theatre modification as per the guidelines. We had to have a dedicated AHU for each OT. Wall paint with antibacterial and antimicrobial properties had to be used. OT doors were made automatic and hermetically sealed and touch-free. Provision of safety against static charge. Separate power circuit for equipment like laser, anti-static flooring, and zoning had to be done for CSST. These were some of the changes that we made. This was pre and post. And a lot of signages had to be done. The third challenge was record keeping and compliance. OPD records are electronic, and we have only manual medical records only for consents, imaging reports, surgical notes, and discharge summary. There were major lapses in proper documentation, unsigned consents, or incomplete doctor's notes, incomplete discharge summary. I'm very sorry to say that most of the non-compliance were from the doctors. And we designed the EMR in such a way to comply with NABH requirements to ensure the completeness. Clinical and non-clinical staff were trained and retained to comply. And we ensured that we do the random sampling of both the electronic medical record and the manual medical record on a daily basis. And this was presented in front of the top management every month to ensure the compliance. So this is how we ensured the completeness. The fourth challenge was untrained staff for emergency preparedness. The Human Resource Department identified both hospital-wide and department-wide safety. Hospital-wide were fire, BLS, ALS, PRE, and department for nursing, biomedical waste, hand hygiene, etc. These were the needs that we identified, and the biggest hurdle what we faced was to make these employees attend the sessions. Constant motivation, hands-on training, making this training more interesting by enacting skits, we ensured the compliance. So we had training from external agencies and also in-house mock drills periodically. And challenges related to HIC were recruitment of nurse. As Dr. Murali rightly pointed out, it is a daunting task to have or to maintain the nurse-patient ratio in an eye hospital because attrition of the nurse is very high and most of the nurses use the eye hospital as a stopgap arrangement. So it was a biggest challenge for us, and the HICN appointment and training was the biggest hurdle because every 3 months there was attrition. And training housekeeping staff for personal prophylaxis, biomedical waste disposal, cleaning protocols, and ensuring its compliance was a challenge for us. The staff were reluctant to comply with hand hygiene protocols and using PPE. So this is how we ensured the compliance. The fifth challenge was human resource related. Forming a core team, a multidisciplinary team which had ownership and commitment was a challenge. Staff training, evaluating their effectiveness and retraining was a challenge. We had to credential the staff, form various committees with responsibility matrix, and staff reporting the incidents and risk was a biggest challenge because incident reporting was very poor. And attrition of staff was very high because of the workload, documentation, record keeping, and repeated audits. And to ensure that the staff are motivated, it was again a very daunting task. And the sixth challenge was misconception that accreditation don't have benefits. Many both clinical and non-clinical staff were skeptical. They felt it was a wasteful exercise, time-consuming, and not their job. So this had to be worked upon. And timeline is very essential to achieve accreditation. Staff had to be trained to work against time frame. The core team was given the responsibility to ensure that they meet the deadlines. And finally, financial implications. Any accreditation process is a voluntary process and has huge financial implications because there had to be many infrastructural changes, training, recruitment, and we evolved an appraisal system where we incorporated their contribution to the quality programs in the hospital, and we evolved an appraisal system where the staff were rewarded for that. So we saw a potential. Definitely we wanted to benchmark ourselves. We wanted to reach greater heights, and so we did a thorough SWOT analysis. So what is SWOT? It is a structured, systematic way of thinking about and exploring areas for business development, resource development, and areas of vulnerability. Our strength, I must say, the top management's commitment to quality was unparalleled. There is no separate quality department in our hospital. Each and every member of the organization is involved in quality work, and a robust, dedicated, committed core team with ownership is what we had. And we had a good ISO certification framework which helped in ensuring documentation. What was our weakness? Infrastructural compliance, as I already told you, building completion certificate, fire safety planning, all this we tried to ensure, but certain things which were dependent on the state government were a challenge. ISO standard compliance had enormous data, but we had to convert them into meaningful indicators. And as I already told you, incident reporting system staff were very reluctant. The opportunities, as we can see, were plenty. We understood that it stimulated continuous improvement, demonstrated commitment to quality care, and it helped us, we understood that it will help us realize our vision of being a leader in eye care domain, and it provides access to reliable, certified information on our qualities, infrastructure, and level of care. And definitely it raises the confidence in eye care services. It provides an objective system of empanelment by insurance and third parties, opportunity to benchmark in healthcare industry. One of the threat which was a major threat, was staff who were skeptical were demotivating their team members. So we try to conquer and grow with pride. Quality journey is tough, challenging, and requires tremendous effort. However, it is rewarding and worth the effort. And with this, within 1.5 years, we were the first eye hospital to be accredited for full standards. We saw the opportunities, came forward to claim it, and finally conquered it. The current scenario has changed. NABH has eco standards. Government and insurance companies have felt the need for standardization in hospitals. Awareness among medical fraternity and general public has increased. Training programs are there which help in preparing for accreditation process. To conclude, accreditation system needs unparalleled support and commitment from top management. Dedicated core team with sound action plan and implementation methodology within a time frame is very crucial. A thorough knowledge, skill along with human and financial resources are indispensable. Prompt, unbiased internal audits with gap analysis is a must. Motivated and dedicated staff with ownership are an asset who make quality journey smooth and successful. Thank you for your patient hearing.
Thank you, ma'am, for the comprehensive insight into the challenges and the advantages of NABH accreditation. Now I invite upon stage the CEO and Director and Head of Department of Anesthesia of Netradama Super Specialty Eye Hospital, Dr. Suman Shri, who is also the organizing chairperson of OFISACON 2019, for her talk on clinical audit in ophthalmic practice. She's an active member of ISA, OFISA, and an NABH assessor. She has special interest in QMS clinical audit, pediatric ophthalmic anesthesia. She's a recipient of multiple awards and accolades for quality to our hospital. She's also the driving force and motivating a number of clinical audits in our institute. So I would request ma'am to give us the talk.
Thank you, Dr. Dwani, for the very kind introduction. And good afternoon to everyone. I hope you're all awake. Well, clinical audit is a mandatory component of the accreditation process, as Dr. Murli and Dr. Savitha has already mentioned regarding our NABH accreditation process. So let me try to demystify what clinical audit is all about. How many of you are already accredited for NABH standards, either SHCO or ECO or full hospital? Okay. And how many are interested in getting into accreditation? Good, okay. Well, you have to basically perform clinical audits regularly in the organization if you are planning to take up the accreditation under the NABH standards, whether it is ECO or SHCO standards. So let us say, what is clinical audit? It's basically a quality improvement process seeking to improve our patient care and outcomes through a systematic review of care against explicit criteria and the implementation of any change for the better. So the various aspects of care like structure, process, or outcomes can be selected. It all means asking whether we do the right thing at the right time to the right patient. And that is clinical audit, in simple words. So according to the eye care organization, NABH Continuous Quality Improvement Standard 5, it says there's an established system of clinical audit where the medical staff participates in the system. It includes clinicians, optometrists, administrators, nurses, etc. The parameters to be audited are defined by the hospital. At least 4 clinical audits in patient care aspects, and I assumed in any one audit cycle, which is reaccreditation is once in 3 years and surveillance is once every 18 months. So I think every 18 months at least you should have 4 clinical audits in place. It could be retrospective or concurrent or prospective against very predefined parameters to eliminate bias. It could be disease-based, cost-based, based on morbidity like length of stay, etc. The aims, the objectives, standards, the parameters, audit checklists,
sampling methodology and guidelines, and finally, audit report is prepared. So it encompasses all aspects of clinical, optometry, or nursing care. Finally, you have C, which says you maintain both patient and staff anonymity. So you use the UHID and the employee ID numbers only when you do a clinical audit. You don't take names. All audits are documented, analyzed, and the corrective preventive actions are implemented with root cause analysis. Now let us come to the meat of the matter, the aims of a clinical audit. It is basically to measure the gap between an ideal practice. How do you know an ideal practice? Something which is determined against certain society guidelines or some evidence-based medicine, against the actual practice which you measure in your own clinic. So the purpose is very simple and very clearly stated. It is just a critical analysis of your own skills as a clinician for self-improvement and the system which delivers the patient care, that is the environment in which you deliver this clinical care. So what are the prerequisites of a good clinical audit? A good record-keeping system carried out by fair, impartial professionals, clinicians and optometry staff, and the initiative should come from within. Intention should be to effect change for the better. It is not a bias, it's not a fault-finding exercise. Please remember that. So it has 5 parts. The process has identification of a problem or an issue or something you would like to improve. You set certain criteria standards. Thirdly, you observe the practice by capturing data. Fourth, you compare the performance against the standard or criteria that you want to follow. And finally, you implement change. These are the 5 stages of a clinical audit. It is usually a standards-based audit to see if standards are met. Clinical audit is not an adverse incident analysis. It is not a peer review, it's not a meeting, like we say, morbidity, mortality meeting. It is not a patient survey. It is something that a clinician performs to evaluate his performance. You may wonder, what is the difference between research and clinical audit? I'm sure all the students here will know that most of us are oriented during our education towards generating research projects, research programs. But very of you would have probably performed a clinical audit. So research may involve experiments which are based on a hypothesis, whereas clinical audit never involves experiments and involves measuring against pre-existing guidelines. Research is a systematic investigation, whereas clinical audit is a systematic review of your current practice in the organization. Research involves a random allocation, whereas clinical audit never involves random allocation. Research could be a new treatment, whereas clinical audit never involves something completely new. And finally, research creates new knowledge about effectiveness of a therapeutic approach, whereas clinical audit answers the question, are we following the best practice guidelines? So finally, it can be legitimately viewed as a final stage of a good clinical research program in your hospital. You may wonder, what is the difference between medical audit and clinical audit? Next. So medical audit is a peer review of evaluation of the medical care through retrospective or concurrent analysis of medical records. It aims to improve quality of service which is rendered by the doctors, whereas clinical audit is multidisciplinary in activity and aspects of care, like we say structure, the process of care delivery, or the outcome of surgery, etc., are selected and evaluated. It is multi-sectorial. It could involve the clinical staff, the social service wing, education wing, etc. Now, you may wonder, is it a medical record audit? Is clinical audit just a medical record audit? No. A medical record audit is only focused activity where you check timeliness, legibility, completeness of the medical records. It could be done even by the non-medical personnel. Now let us come to the actual clinical audit cycle. You measure a baseline and you set standards. Then you measure the practice through data collection. You assess your performance. You identify an opportunity for improvement. You suggest the change, implement the change, and finally evaluate it and review it. This is a complete cycle of audit. So you have 5 stages. You prepare for the topic by selecting the topic. You select the criteria. You measure the performance, make the improvements, and sustain it. Let's come to the first stage. There are 5 elements of clinical audit. You have to involve the users in the process who select the topic, define the purpose, provide the necessary structures. And selection of the audit team is known as a clinical audit committee. You create a committee, group of people who analyze this findings of the clinical audit. It could be the medical superintendent, it could be your clinicians, it could be representation from the nursing, optometry, your pharmacy, or paramedical staff. So let us, first of all, select a topic. It could be structure-based, process-based, or outcome-based. So what is a structure-based? Environmental factors like adequacy of the physical space, personnel, HR adequacy, or skill competency matrix. Others could be equipment, whether it's safety and calibration of the equipment or completeness of medical records. Most common projects are process-based. Like, for example, the care which has been given by the clinician or the paramedical staff. Actions and decisions taken by the doctors, or examples could be the prescription audit, hospital referral rates, laboratory optical conversions, etc. Some of them could be even outcome audits, like changes in the patient's current or future health based on, like you describe the effectiveness of the surgery or the medical care. Examples could be, we have visual outcomes following phacoemulsification, which was one of the Lean Six Sigma projects. So it could be visual outcomes, it could be patient satisfaction, etc. So now how do you choose a clinical audit topic? So it should satisfy the 3 H's. The first H is, it should be a high volume, or it should be a high cost, or it should be a high risk area. It would be ideal to perform a clinical audit which satisfies any one of these 3 H's. It should be of local clinical concern, it should have good practice guidelines, and there should be some source of information. This is a sample of how we decided on prioritizing our topic. In fact, we had a brainstorming session among the clinicians during a clinical audit. They came up with many, many topics. Then we distributed this, and we told them to fill up this. Is the topic high risk? Is the topic high volume? Is there wide variation? So they answered this, and finally we zeroed in on the topics. Now, very often we have something known as algorithms or clinical pathways. These are structures, multidisciplinary plan of care, which is designed to support the implementation of certain guidelines. It defines the optimal sequencing, timing of interventions. It could be diagnostics or therapeutics, either one. So there should be a timeline. There should be a care or activity categorization. There's some criteria of outcome, and finally a variance record for an algorithm. So now you may be knowing about the Basic Life Support American Heart Association guidelines, which clearly tells you step 1, step 2, step 3, step 4. So there is an algorithm which is followed. We did a clinical audit on red eye. So if a patient comes with a red eye to Netradama, this is the protocol that is being followed. This was one of our first clinical audit algorithms, which you will find in the OPD, which is very important for even new staff education, like new doctors getting into the organization. So now you have selected your topic. What is the next stage? We have to decide the aims, the objectives, and the standard. So how do you define an aim or a purpose? You say to improve, to enhance, to ensure, to increase. Objective is like to ensure timeliness, effectiveness, or appropriateness of care. So one example would be to ensure the timely initiation of BLS and ALS in the organization. So that was one of the clinical audit projects that we took up. Another one was to improve the post-operative visual outcome following phacosurgeries. to ensure that cataract patients are treated appropriately, to ensure timely treatment of cataract patients. Then we create a standard. What is a standard? It has a target, which is a percentage. Then you have a criteria, which is a statement of what is being measured. And finally, a yardstick. So I will give the same topic. 94% of cataract surgeries will achieve a visual outcome of spherical component within plus or minus 0.5 diopters. So what is the target? 94%. Criteria would be a visual outcome following phacosurgery. And what is the yardstick? Within plus or minus 0.5 diopters. That is how you create a standard. Is that clear? Some other examples would be 100% of patients requiring urgent appointments will be seen on the same day. So you have a target, a criteria, and a yardstick. So every project must have at least minimum 2 standards. So this was how we did our CPR project. Recently, in fact, Dr. Dwani was involved in our pterygium clinical audit project, which came out very well. Due to paucity of time, I'll just skip the details. This was how we made the standards for the pterygium project. And this was the beautiful clinical pathway which she has established for the management of pterygium in Netradama. So it's very important to develop smart standards which are specific, measurable, agreed, and relevant, and theoretically sound. Then you measure the performance in the third stage by sampling and data collection. And this is how our CPR recorder sheet looked, and including our post-event analysis. Within 1 minute, time to CPR. Within 2 minutes, code blue team arrives. Within 3 minutes, the defibrillator is ready for shock. So these were the 3 targets which were measured. So then we do a detailed data analysis depending on various tools. We also use what is known as the Kipling method. I have 6 honest serving men. They taught me all I knew. I call them what, where, and when, and how, and why, and who. So this is a very famous mnemonic that is used to analyze all root cause analysis, basically. So finally, you sustain your improvements in the last stage, and you create a report with all the details. So there are many benefits to the doctors, to patients, and to the hospitals. And this is how our Lean Six Sigma project has evolved over the last 8 years. Right now, we are at Lean Six Sigma 3.16, which means that we are at almost 94.5% success rates in our cataract surgery of plus or minus 0.5 diopters. So the key message being, now it is not just a data collection exercise. It involves measuring current patient care and outcomes against explicit criteria. Expected to improve your practice, you need to document the report, implement an action plan, and most importantly, re-audit after change is implemented. These are some examples of various ophthalmic topics. Thank you very much.
Clinical audit is indeed a mirror to one's practice. Thank you, ma'am, for a motivating and inspiring presentation. Lastly, I would invite Dr. Namita Anagol for her presentation on Bugs Away, Best Practices of Hospital Infection Control. Dr. Namita is a senior consultant ophthalmologist at Netradama Super Specialty Eye Hospital with a special interest in uvea and anterior segment. She's also HIC officer and internal auditor for ISO 9001-2015. I hand over the mic to Dr. Namita for her presentation.
Good afternoon, everybody. Thank you, Dr. Dwani, and thank you, Dr. Suman, for giving me this opportunity to speak. I'll be talking today about the best practices in hospital infection control. A short introduction before I go into the details. Hospital infection is an infection acquired by a person in the hospital, manifestations of which may occur during hospitalization or after discharge from the hospital. The time duration post-discharge is guided by CDC and WHO, which has different criteria for different types of patients. So World Bank studies have shown that almost 2/3 of developing countries spend their 50% of the annual expenditure is for healthcare budgets. So an effective infection control program is beneficial because that will reduce the spread of HAIs, reduce morbidity, mortality, and of course, reduce the healthcare costs. So what are the common sites of infections? You have surgical site infections, urinary tract infections, lower respiratory infections, and bloodstream-associated infections. So what are the root causes of HAIs? Generally, use of advanced and complex treatments without adequate training and supporting infrastructure, invasive devices are some of the common causes, but the most important is inadequate sterilization, disinfection practices, inadequate cleaning of hospitals, and high hygiene practices. So what are the key contributing factors? Increasing use of invasive medical devices, then antibiotic resistance. Nowadays, which we see everywhere, almost all the drugs, there is some amount of resistance. But the key factor would be inadequate standards and practices. So the hospital infection control program I will be discussing based on 4 important criteria: hand hygiene, the biomedical waste disposal, sterilization and disinfection, and healthcare worker safety. So first thing would be the hand hygiene. So what are the questions you ask when you want to do a hand hygiene program in the healthcare systems? The most important would be, first, before we initiate, as the previous speakers have said, we have to have a top management commitment because you need the financial support, the manpower support for the hospital infection control activities. Then the hospital infection committee has to be formed, which will take care of the policies, the procedures, lay down the guidelines for the various processes. And the infection prevention control team, which will look into the day-and-day management of the hospital HIC activities. Under the Hospital Infection Control Committee, we have the Biomedical Waste Management Team, which fulfills the legal obligations for the hospital infection control. They do the daily rounds, the monitoring. Then they also look into the transportation, the storage, the disposal of the waste, and the data generation for biomedical waste. So these are various infection control activities like surveillance, hand hygiene compliance, monitoring of the sterilization, biomedical waste disposal, surveillance of healthcare worker safety, and periodic evaluation of data, especially from the lab, to identify the resistant infections. So we first start with hand hygiene. Hand hygiene is a cornerstone to prevention of infections. Various studies are put across various countries and continents. In 2009, a study done by NIH showed the hand hygiene compliance in ICUs was only 37% and 51% in non-ICUs. In 2016, CDC guidelines have shown an average hand hygiene across healthcare organizations across the continent of only 40%. The closest which I have come across is in Australia, wherein 80% was their hand hygiene compliance. So WHO has given an approach for hand hygiene improvement across any organization. The first will be the hand hygiene improvement strategy. A system change has to occur in the hospitals. So you have to have the various hand hygiene equipment available, so hand wash, sterilium. Then next, the training and education of the staff, observation and feedback from the concerned people, and reminders in the workplace for hand hygiene, and of course, create a safety culture in the healthcare organization. The 5 steps to implementation, they take around 1 year, which starts with preparing the facility for hospital infection, for hand hygiene and infection control, evaluate the baseline hand hygiene, implement your programs, a follow-up evaluation, and finally an action planning and review of your system. So when you're going up with hand hygiene, it is important to answer 4 questions. When to observe, how to monitor, and how to promote. So when do you observe? Very simple guidelines given by WHO are the 5 moments of hand hygiene. The first moment is before touching a patient. Second is before any clean or aseptic procedure. Third is after exposure to body fluids. The fourth is after touching a patient. And the fifth is after touching a patient's surroundings. These are very basic things. Probably most of us during our college days itself, we are aware of it. But most of us tend to miss these things. And WHO has put it in a perspective. So how do you monitor? Again, WHO has provided guidelines. You have the 7 steps of hand hygiene. Generally, for most cases, a hand rub is sufficient and around 30 seconds. But when you have the hands which are visibly soiled hand wash is important, especially in the Western world. The Clostridium difficile infection is very common. So therein, hand wash is a must, and that is around 60 seconds. So why do you have, like most of the thing, why do you need 7 steps of hand hygiene? It is seen by various experiments and studies. Certain areas of the hands are missed when we do a regular hand washing, like thumb, tips of the fingers, or in between the fingers. So the 7 steps have been devised for you seeing that all the parts of the hand are washed. So how do you monitor? Would be the third question which we need to ask. You have the WHO hand observation form, which gives you the opportunities, the actions, and what was used, whether gloves were worn, action was, what was the type of action, and whether it was missed. And then you can do the hand hygiene compliance by the actions done, by the opportunities provided into 100, and then benchmark yourself both nationally and internationally. So how do you promote hand hygiene? Now just training and teaching them how to do may not be sufficient. So regular training programs have to be happen for the staff. The first training happens when the staff are inducted. Then regular training every 6 months or so, and even bedside training. In our organization, we have poster display across the hospitals to inform both the patient and the staff about hand hygiene. Then we have conducted poster competitions for the staff, wherein they have done posters for hand hygiene. We also have our server desktop, which comes up with hand hygiene and biomedical waste. We have had a small brochure for hand hygiene. These are for our nursing staff. And then we conducted a skit by our nursing staff for both biomedical waste disposal and hygiene. So these are just some examples of how we can promote hand hygiene across the organization. So the next part of the talk I would like to talk is by the biomedical waste disposal management. So biomedical waste is the waste which is generated either during the diagnosis, the treatment, or immunization of human beings or animals, or in any research activities. As per the Government of India came up with the rules first in 1998, and then they were revised in 2016, and the newer amendments were in 2018. So there are 4 essential steps which all of us should remember when we have waste disposal. The first is segregation of the waste at source, then the interim storage and transportation from the collection facility to the treatment facility, and the final step would be treatment and final disposal. So what are the categories? I think most of NIH hospitals or accredited hospitals will know there are 4 categories of waste. We have the yellow, the red, the black, which is general, and the blue containers. So this you will see in the biomedical waste guidelines. You have yellow containers, commonly are the infected waste, human anatomical waste, the animal anatomical waste. You have the soil waste, expired or discarded medicines. Then you have chemical liquid waste, and also the discarded linen bed which have been used by infected patients. The red is mainly the contaminated waste which is recyclable, and white are the sharp containers, and blue are the glasswares. So regular biomedical audits have to be happen in the organization, and this will usually be done by the biomedical waste management team. At least once in 2 months they have to meet and look into the different aspects, the amount of general waste generated, the different categories of waste generated, and the percentage of infectious waste to the general waste. A barcoding system has to be utilized as per the 2016 guidelines. So we have a barcoding which has around 13 numbers which tell which organization, which ward, which color waste, and which floor was it. So in this way we can track our biomedical waste from the generation to the treatment facility. And it's also important that most of us are using the outsourced treatment facility, so regular visits to be done at least once in 6 months. And important to record the accidents which happen during biomedical waste handling. These are the reports are sent across once in a year at least to the Central Pollution Control Board and uploaded onto their web page. So the third part of the talk would be a prevention and control of infection. So the goal of any organization infection prevention and control program should be to identify and reduce the risk of acquiring and transmitting infection among healthcare workers. So a set of precautions known as universal safety precautions have to be followed. These are a set of practices which have been designed to prevent transmission of HIV, hepatitis, and other bloodborne pathogens when providing first aid or healthcare to any patient. So to whom is it applicable? It's applicable to all workers across the organization who come in contact with the patients. And against what are we taking these precautions? It's mainly blood and body fluids. Certain fluids, as you are aware, may not be contaminated, but it is important to remember any body fluid that has blood in it is a risk for transmission. So personal protective equipment has to be worn by the staff when they're handling infectious patients. The type of equipment they wear will depend upon the type of expected exposure. So for the healthcare worker safety, it is important that a general health checkup should be done at the time of recruitment and a yearly health checkup. Staff immunization program should be done. Their anti-hepatitis B antibody titers should be level. Documenting needle stick injuries and regular training is a must. These are spill protocol and the needle stick injury protocol. These are some of the guidelines we have for exposure to needle stick injury. A pre-exposure vaccination has to be done by all staff for hepatitis B. The important part next would be the operation theatre, which is the heart of any hospital. So the hospital, so as Dr. Murli was saying, air handling unit is very important from all the hospital, including in the eco standards, and certain guidelines have to be kept wherein at least 25 air changes have to occur with 4 fresh air changes. A temperature has to be maintained. AHU has to be validated every yearly. CST is again the most important part of an operation theatre. So you have the physical parameters for monitoring your CST steam stabilizers like temperature, pressure, time. You need the exposure control using the autoclave indicator tapes. The load control is by the biological indicators. At least once in a week we should use. You have the pack control, which is based in each pack, and equipment control. So these are some of the stabilizers we keep, indicators we use. Various records have to be maintained in the CST, the temperature record, the autoclave record, the physical parameters like pressure and all what we are measuring. A disinfection protocol has to be followed, and disinfectant ideally should be depending on what you're cleaning and how. Staff in the OT who are cleaning should be trained for it, and OT mopping should be they should be trained in a unidirectional flow in a S or H-shaped system using either a 2 or 3 bucket system. Important is the training which I've been saying from right in the beginning of my talk. An antibiotic policy should be established because it's the largest therapeutic group of medications which we give in any hospital. And this is important that you have an antibiotic management team which will decide on the prescription of antibiotics. So you have first choice antibiotic, restricted choice antibiotics, and reserve antibiotics. So we have, when the reserve antibiotics are used, we have a form which they take special permission for the same. Surveillance has to be done regularly, both active and passive, in all the high-risk areas of the hospital, like OTs, ICUs, HDUs, etc. And to conclude, I would like to say, it is important to measure the various quality indicators, the surgical site infection, needle stick injuries, and important to do a root cause analysis for deviation. A training should be done on a regular basis. Remember, quality is a continuous process. It requires a lot of dedication and commitment by not only the top management, but by the staff who are working the same. Thank you so much. It's important that we should be needle start to avoid needle stick injuries. Thank you.
Thank you, ma'am, for such a detailed and well-researched presentation. I think we can take a few questions if anybody has any questions.
Does anybody have any questions on the implementation of NABH standards or? Yes, Dr. Pragya. Somebody give a mic to Dr. Pragya, please.
So in the HRM chapter, there is one objective element which says that the antecedent of your staff should be checked. That is for the full standards. So for a bigger hospital, we have these agencies who do it. For the smaller hospital, is there any other method that we can?
So sometimes these are difficult.
Yeah, it's difficult.
Also a little, what do you call it, as touchy, sometimes.
Yes.
So what we do is the intent has to be met. You could do it in 3 ways. One, he himself gives, that there could be a self-declaration. He or she could give a self-declaration. Second is, once, you have decided to join, either that organization or the previous organization, you or someone could just call up and ask, so that's how, and just note it down in his own case record. That is itself considered as okay. So somewhere there has to be a system where you have checked it. So now it is always possible you may not get the right this thing. So if as an organization you can get a third party to do it, it is very good, but not all could be done. In such cases, a self-declaration and maybe with the present employer or the previous employer or someone who had been with them in the past should be good enough.
So we can have a hospital policy on this and implement.
Yes.
Okay.
For doctors, we have something known as a good standing certificate, which is given by the MCI. Like in Karnataka, it is given by the Karnataka Medical Council. So all doctors, we do take a good standing certificate from the Medical Council.
And another question is regarding the fire NOC. So as you said, if it is it's less than 15 meters, they say you can have a third party certificate. But for full standards, like when we applied, the NABH has requested that there should be at least a communication with the fire department. So
it is like this. So let us assume yours is less than 15 meters.
Yes.
So now you have to show or prove that you don't need it based on a government notification or something. That is one.
Okay.
Second is, there are two aspects to fire safety. One is the structural safety. And nowadays, in places like Karnataka, they have started issuing something called as a safety clearance. It is not for the structural. It is for to know whether your people are trained, whether you have the equipment in place, whether, those aspects. So they come and inspect. So that is what the NABH is currently. So first, let me make it easier for you. So one, you give a notification saying it is less than 15 meters. Two, you get an approved structural engineer to tell that this building is less than 15 meters. Otherwise, how will NABH or someone know? And say, based on this, I am not applying for a fire NOC. However, I have a third party. Certain states, as I said, like in Karnataka, there is something called as a fire safety clearance certificate, which is essentially looking at the practices, the other infrastructure in terms of fire extinguisher and all that. So that is what the NABH asks for. So suppose NABH would not know which states have and which states don't have. So that's why we say at least you apply for it, take a third party, and then, forget about NABH. Even from your aspect, you are safe. You have applied, you have done all this, you have done a third party, you have complied with it. So God forbid, even if there is a fire, you are safe.
So it has to be done every year?
That doesn't say every year. Now, the fire safety certificate in Karnataka, some places they give for some hospitals they give 2 years, some hospitals they give 1 year, some 3 years. So if it is 3 years, it's once in 3 years. If it's 1 year, every year.
Okay. Thank you, sir.
Regarding single-use medical devices, is there any policy other than to use it for a single time?
So this is nobody, I don't think anyone in India, including the ICMR, has an answer, to be honest. So having said that, see, this is a practice which is being followed everywhere. If you look at no guideline, no government, nobody will ratify saying that this is fine, including NABH. Nobody can say this. All I can tell currently is ICMR has formed a committee to look at reuse of single-use devices. I was also a part of that committee for 2 meetings. So once a lawyer, got up and said there, sir, if this goes to a court of law, they will ask you to show the package. The package will say single use only. So the moment you say single use only, then the case is straight away dismissed there. So I had a different sort of a suggestion there. So I said, the guideline what we need to give is not to reuse it. We can say, if you are reusing, follow these criteria. So we are not, ICMR is not going to tell reuse. If an organization is reusing, follow the criteria. And what was suggested at that time was, if we are using, first inform the patient that some of these things could be reused and he or she understands the implications of the same, number one. In case if the patient does not want something to be reused, there has to be a methodology where it is not reused and he pays extra. That's fine, Second is, in your reuse policy, how you are ensuring sterility and other things to be maintained. So that is what currently many hospitals follow. Now, if you ask me which is right or wrong, I have no idea, but at least something which is logical is right. But on a serious note, ICMR is looking at this.
Something to add here. Very often when the assessment is going on, they ask, do you have a reuse policy and protocol? So you need to establish a reuse policy in your own organization, which is compliant with all these standards. You ensure that the sterility and all the calibration, everything is adhered to. So finally, even if it is being reused, you say this is the policy that is being followed, maybe single time or twice or whatever. So you establish your own reuse policy according to some guidelines. That's it basically.
Ideally, yes.
AHU is debatable in ophthalmic practice, sir. Sir.
So there was, I think I was not a part, I think Dr. Basil would probably know, there was a lot of debate, but finally it was decided. So look at it this way. The ASHRAE guidelines, which is what is used in the West, any air conditioning system in a hospital should have air exchange. And air exchange can happen only if there is an AHU in a system. So your window AC or a split AC or whatever, air exchanges don't happen. If air exchange doesn't happen, whatever is there will keep recirculating. They don't get out. So that is why AHU is there.
So I think we've come to the end of the session. I request Dr. Dwani to wrap it up.
So I would request Dr. Sumanshri ma'am to felicitate the speakers with a memento. Dr. Murli Srinivasan. Dr. Savita Arun. Dr. Namita Anagol. I have an announcement to make before we break for tea session, is that tomorrow's sessions will be conducted at the same venue, and I would request everyone to kindly ignore the misprint on the lunch coupons. With this, we conclude the academic sessions for day 1 of 5th OFISACON 2019. We will have a short tea break, and I would request everyone to assemble here at 4:55 to start with the inauguration function. Thank you.